Mr. President of the Foundation, dear members of the board of the Foundation, dear members of the Scientific Committee, dear awardees, dear attendees, dear colleagues, ladies and gentlemen, on behalf of the Faculty of Medicine, I welcome you to this fantastic symposium. I think it will be a great day of science with fantastic presentations. I think it's really a very, very good opportunity after these 2 years of pandemic to be again in presence all together. Science is not only the presentation of data, as you will have today, but it's also a matter of exchange between scientists during coffee breaks, for example, and I'm sure, all missed these opportunities to be together during these 2 years of pandemic. I would like also to take this opportunity to thank the Foundation Louis-Jeantet, which has been very supportive for the Faculty of Medicine throughout the years. And this support has led to different initiatives. So one of them is the Louis-Jeantet professor positions that we have. The other one is also to support translational projects that are led by colleagues from both sides of the street. So the other side is the hospital, and here is the faculty with basic science. And these translational projects are usually led by a co-PI, coming both from the clinical side and from the basic side. And there is another initiative that I think is very relevant, very important, is the support for medical students who are at the beginning of the medical studies and who start to have some experience and internship during summer in labs or research groups. And with the support of the foundation, we pay a small salary for this internship. And for them, it's the first step for a scientific career. And I think this is very important for the future and for the future of our faculty. So with all that, I leave you with an excellent day. I'm sure that you will have a lot of pleasure. And I leave it to Denis Duboul to give you additional introductory words. Thank you.
Thank you very much, Sam. Thank you, Mr. Dean. Dear colleagues, dear friends, dear students, welcome. Welcome to this symposium, this 2022 symposium from the Louis-Jeantet Foundation. I'm absolutely delighted on behalf of the Foundation to welcome you all in this medical faculty. This year, it is of course a very special symposium. As all of you, the Foundation for the past 2 years suffered from the pandemics, and we could not celebrate our laureates the way we wanted to. And this year we decided to do this by organizing an entire symposium and bringing in Geneva the laureates from the 2020, 2021, and 2022 class. That generated this somehow extraordinary lineup of speakers we can offer you today. And before we start this symposium, I would like to give a few thanks. I, of course, would like to thank the Dean and the medical faculty for the collaboration and for welcoming us in their site. I'd like to thank my dear colleagues from the Fondation Louis-Jeantet, from the administration and the technical staff of the Medical Center for organizing this event. And of course, I'd like to thank all the laureates for joining us in Geneva. Unfortunately, few of them could not attend. Not unsurprisingly, in fact, there are still many viruses around. and they will deliver the talk through our webinar system. That's it. I suggest we start this symposium, and I'm absolutely delighted to chair this first session and to welcome Erin Schumann as the first speaker. Erin studied in University of Southern California. Then she went to Princeton for doing a PhD in neuroscience. Then she went back to the West Coast in Stanford and then in Caltech as an assistant associate full professor in 2010. All through this time, she was a member of the HHMI, and she was appointed at the Max Planck Institute in Frankfurt, the Max Planck Institute for Brain Research in Frankfurt in 2009, where she has spent the last almost 15 years. I don't think it's necessary to give a long introduction on Erin's work. The laboratory has been likely the leading laboratory over the past many years in studying the protein synthesis and degradation within neurons, and in particular at synapses. And this is for this work that she received the Louis-Jeantet Prize for Medicine 2020. Erin, please. We should be now in contact with Graziella Pellegrini, hopefully. As I said in my introduction, unfortunately, Graziella and Michele De Luca will deliver the talk online.
Okay. So good morning to everybody. Sorry.
Good morning. So let me say a few words. Graziella Pellegrini studied chemistry, pharmacology, and pharmacy at the University of Genoa. She then did a postdoc in Genoa and became then vice director of the Laboratory of Tissue Engineering at the Istituto Dermopatico dell'Immacolata in Roma. She's now director of research and the Research Center for Epithelial Stem Cell in Venice and professor of applied biology. Now, together with Michele De Luca, they coordinate a program of cellular and gene therapy. It is for this reason that they actually received, co-chaired, the Prix Jeantet for Translational Medicine in 2020. Thank you very much, Graziella, to join. The floor is yours.
Okay. I'm going to talk about epithelial stem cell as a real tool for effective regenerative medicine. And starting from the beginning, some years ago, on the paper on Nature was described this kind of valley of death for translational research. And this was representing the perception that the significant resources being put into biomedical research and the huge strides made in understanding disease mechanism are not resulting in commensurate gains in treatment, diagnostic, and prevention. So this raised some public skepticism on the translation, and the question was, is it possible to fill this gap? Indeed, the real challenge is to translate cell and gene therapies, which are highly complex technologies, into safe and effective routine clinical practice to improve the patient lives. But starting from the external side of the body, the epithelium, they are a very interesting tissue to focus on, as they are defining in our bodies internally and externally, and they contain our cells. They are extremely specialized, and we focus on that as they are the largest body tissues. They are highly renewing. This means that they need for stem cell. They are highly specialized with various differentiation lineages, with huge differences in various signaling and specific microenvironment with different matrices. The regeneration affects different medical areas, of course, because they can affect ophthalmology, dermatology, plastic surgery, and whatever, urology, but they are easily accessible. They can be easily removed, especially in a small amount, and extensively studied. The largest body tissue to start with is the epidermis. This represents a very significant part of our body weight, and it was the first tissue that was developed and cultured ex vivo, as in 1975, Professor Auergreen was able for the first time to show the ex vivo creation of replacement tissue intended for subsequent in vivo implantation, representing the earliest attempt at engineering tissue. And we were fascinated with the ability to culture and reconstruct human parts in vitro. He was able to identify cells able to rebuild the epidermis in vitro, and he was able, together with Nicholas O'Connor and Gregory Gallico, to transplant those cultured tissue on burn patients, saving their life. This was in 84 of the last century. In 86, as we were really fascinated by this technology, we reproduced the technology in Europe as the first in Europe by regeneration of the human epidermis for very large lesion as a life-saving treatment for third-degree burns, affecting over 50% of the body surface, which means a total burn of approximately 80–90%, 50% of which of third degree. Those patients were considered almost dead when they were developing this kind of severe lesion. And we were able to save in 86 Franco, who is represented here in a picture of 2014, and was able to reach up to 30 years follow-up after the transplantation of the whole body surface by cultured epidermis in Italy. But I mean, this technology revealed quite soon its limitation, as of course there was an extensive scarring of those patients, and some of them were immobilized on a wheelchair because of the scar retraction. So we developed an evolution of this technology that was applied for the first time in Ljubljana burn unit on a patient, was a 17 years old patient that was totally burned by gasoline. And the new technique included the addition of a special scaffold, reabsorbable scaffold made by human fibrin glue, chemically modified, that was reabsorbed within a few hours in the body, obtaining a large amount of tissue in a shorter time and very fast adhesion on the wound bed. The addition of dermis, synthetic or human dermis on the wound bed was producing a final results with a reduced scarring that allowed the people, as you can see from this leg, to walk and to move normally, despite, of course, some scar due to this severe lesion. And we published those patients with very high success rate obtained in Vienna, but also in Italian burn in 1999. But following the study of this burn patient, during the study, we observed the presence of melanocytes. Those cells that color the stain of our skin. And interestingly, those melanocytes, when were cultured together with the keratinocyte, despite their low speed rate in growth, and when they were mixed together with the epithelial cells, they were impressively able to be interspersed in the basal layer of the epidermis, but they were unable to locate properly if added to other epithelia, highlighting the needs of special epidermal signaling for their organization and their function. And indeed, following many studies on their survival in culture, their capability to grow, and the amplification scheme and the preparation of the wound bed, we developed by the co-culture of epidermal cells and melanocytes, we developed a treatment for stable vitiligo, where the people born without melanocyte in a specific area. And we were able to restore the pigmentation, as you can see in the picture of those patients, making them able to stay under the UV light without risk of carcinoma and being able to have a normal social interaction without psychological problems. And again, this was published at different stages. The approach to this therapy was obtained by a very conservative surgical technique, producing a very small, with a very small power in electricity and a special needle that was able to produce a superficial burning of the dermis without altering and burning the dermis, as you can see by maintenance of the dermal papilla after detachment. And this kind of approach was used also for the first treatment we did for gene therapy on junctional epidermolysis bullosa that Michele De Luca is going to show after me. But following this, the application of melanocyte in vitiligo and piedaldism, the analysis of follow-up data revealed the importance not only of the quality of culture, but also of the microenvironment. As looking at the different engraftment in different areas of the body, we observe a very high success rate in all those areas of the body, whereas there was a limited results in the periocular and perioral area and negligible results in hands and feet, showing that the microvascular network and the peripheric temperature and the microenvironment signaling were strongly affecting the final results on the patient. But going ahead in the study of this this technology, the reported take rates of cultural epidermis, for example, in burns, but sometimes also in the vitiligo, by different groups with applying different culture system, varied a lot, because were reported success rate between 0% up to 100%. And it must be noted that the proliferative compartment of the epidermis, for example, but even of other epithelia that is indicated here by green and red cells, the proliferative compartment is located in the basal layer, containing epithelial cells with a different capacity for multiplication. These have been identified by clonal analysis as holoclones, representing the stem cell, and meroclones, representing the progenitors, or paraclones, representing the transiently amplifying cells, those cells that do the day-by-day job in wounding, in healing the wound, and short-term proliferation. So, to distinguish the clinical problem from the biological factor affecting the quality of culture, this criteria was used for the evaluation of the sensitive component of the culture destined to clinical application. And the data were reported in different papers on different applications. Interestingly, looking at the different epithelia of the body, you can see that, in vivo, we have completely different phenotype from the stem cell of the skin, of the conjunctiva, covering the white part of the eye, of the cornea, covering the transparent part of the cornea, the ureter, the airway, human airway, the oral mucosa, or the urethra. But fortunately, under a specific culture system, all of them, all the stem cells of the different epithelia, can be identified as they are able to produce the same type of clones, the holoclone, having an impressive capacity for proliferation and an impressive capacity for self-renewal once transplanted in vivo. So this gives us the possibility to identify the presence of stem cells from the different epithelia in vitro before transplanting the patient, producing a sort of in-process control of our culture system to be able to understand when the success or the failure was related to the presence or to the absence of stem cell or to clinical problem. I'm going to briefly show you some of our clinical application as the urethral epithelium, the oral mucosa epithelium, and the ocular surface, to have an idea of the potential of this technology in the clinical application. Speaking about the first generation technology for urethral reconstruction, I have to say that this was tailored for the treatment of hypospadia. Hypospadia is a disease where the child are born without the urethra in the penis, with a small, short urethra, or the case were considered for general medicine, the total absence of urethra in the penis. This is quite a frequent pathology, as one born every 300 is affected by this pathology. And this patient, of course, cannot have a normal urinary function, they cannot have a normal penis, they cannot be able to be fertile and to have a normal sexual life. So this represents a huge physical and psychological problem. The first generation of this technology was based on the idea and the clinical practice of opening the penis, which was devoid of urethra inside, and once the wound bed was prepared, the urethral epithelium was transplanted over the wound bed. This was left covered for approximately 15 days, and then we could observe the regeneration of the urethral epithelium that enabled the surgeon to close again the penis, forming the tube inside the urethra, which was absent before. To overcome the problem of the two-step transplant by opening the penis, a second-generation technology was developed trying to obtain the same results many years ago by endoscopic application of the urethra, cultured and tubularized around a biomaterial. This was a very old style biomaterial. Now we have better material to do that. And this second generation technology led to some success, but a little bit more complication than the previous technology, as the previous technology was able to show the maintenance of open urethra with the follow-up of 12, 16, 18 months with a normal appearance and the tube within the penis that was absent before. But still, the technology was not fully developed, as the pathologic urethra needed some modification and adjustment, as the pathologic urethra had a very low proliferative capacity in comparison with the oral mucosa. So an extensive study was done on several papers to compare the cultured oral and urethral stem cell for the urethral regeneration, to evaluate the biocompatibility of the ectopic application of oral mucosa to rebuild the urethral tube. And this was published together with many biological results. And after the first proof of principle, we developed the third generation technology with the new biomaterials, and now a new pediatric clinical trial is ongoing for the correction of this disease in child and very young boy. But one of the most successful examples of reconstruction was given by the ocular surface. In the ocular surface, we have different epithelia, as we see the white part, which is called conjunctiva, having blood vessels and specific marker, and the corneal area, which is seen as color, but it is a transparent lens, and the color part that we see is the iris below, which is characterized by total avascular appearance, where the vessels stop at the edge between conjunctiva and cornea, and the expression of specific corneal marker. This was the reconstruction of the ocular surface was to treat a form of blindness called limbal stem cell deficiency, producing this kind of appearance of the ocular surface with, of course, blindness, pain, burning, and photophobia, with huge discomfort and problems for the patient. But in order to understand how it works, I briefly show you a movie showing how it works on the corneal surface and the damage. If we look at the ocular surface, as I told, we have two areas, the cornea with a specific marker and the conjunctiva with blood vessels. In the middle, we have the limbus, which is a ring all around the cornea, which is the only area of the cornea having the stem cell indicated here in violet. Under normal homeostasis, they produce progenitors, they migrate over the cornea. But in corneal repair, in case of damage, moderate damage of the ocular surface by chemical of thermal burn, the stem cell can migrate over the cornea, and eventually they are committed to terminal differentiation, repopulating the cornea normally. In case of an extensive damage of the ocular surface, affecting also the limbus, the only cells able to repair the cornea are the conjunctival cells, driving vessels over the ocular surface and producing white eye with opacification and pain for the patient. For this kind of patient was developed the first regenerative medicine treatment in ophthalmology, the cultured limbal epithelial transplantation, called CLET, in 1997. This was the original paper on Lancet. And again, as usual, when you develop the first technology, you immediately understand a lot of limitation of this technology. As the first paper was published after the observation, follow-up observation of 2 patients for up to 2 years after the transplant, but the epithelium, the cultured epithelium, was very fragile and cannot be exported in different ophthalmology centers. So we developed a second generation technology, introducing again fibrin cultured cells with reabsorbable scaffold again for allowing the easy manipulation of the graft and the transportation without damage, and then the introduction of main process control in the course of an amplification process. And in 2010, we published the 10 years follow-up on those patients on New England Journal of Medicine. To make short a very long story with a lot of papers and a lot of research, we were able to characterize the different marks, at least 3 different transcription factors that later were many others were developed and were identified, that were turned on or off depending on the state of the cells in the ocular surface, moving from the limbus to the central cornea, and in vitro in the course of proliferation and differentiation. With the group of 3 markers accounting for slow cycling and self-renewing cells, 1 transcription factor accounting for the high proliferation and migration rate, and then additional transcription factor for the beginning of terminal differentiation in the course of wound healing. And with this in mind, we developed a treatment for unilateral or partial bilateral limbal stem cell deficiency, so blindness like this, where 1 very small biopsy, approximately 1 millimeter, was taken to remove by different steps of cell extraction the stem cell that were put in a progressive epithelial purification in a cell-specific microenvironment to select epithelial cells. And after accurate monitoring by in-process control for identity, purity, and potency as requested by European regulatory rules, we could reconstruct on a special carrier the final autologous cultured corneal epithelium for transplant. This technology was, this is the epithelium that we apply on the patient, led to the corneal restoration in patient for more than 10 years follow-up. As you can see, this is the recovery of the ocular surface with the normal appearance and normal function after transplantation, and this is indicated the years of follow-up at the different time of observation, as you can see. Those patients were characterized by multiple previous surgery without any good clinical results and worsening of the condition, but after the culture, the corneal epithelium transplantation, they recover their function and their normal appearance of the organ. But the question raised is how stable is this kind of results over time? And for this reason, we perform an evaluation of the stability over time with an observation period up to 10 years of follow-up. Now, we are collecting the 20 years follow-up, but the results are not still ready. So those patients had at the beginning a window of failure due to surgery or low level of stem cell, but the patient, approximately 80% that were able to overcome the first year, they were impressively stable over time with the recovery of the visual function, and more importantly, the decreased disappearance and severity of individual symptoms in the patient, including some failure. So even some failure had anyway recovered from symptoms, meaning pain, burning, and photophobia. Those patients move from the black vision, no vision at all, to, again, light, color, and shape, as they were before the accident. The development of this treatment was acknowledged by European Medicinal Agency as that included Holoclar, which is the brand name of this treatment, in the list of its significant milestone in the last 20 years, as they approved the use of Holoclar for all Europe. But I mean, the clinical application now is ongoing in 10 different European countries. Of course, this kind of results, positive clinical results, led us to increase the complexity towards gene therapy. Michele is going to talk about it, and organ-like structure, trying to solve more complex pathology. And just to give you a very fastly some example, the rebuilding of the whole corneal structure, corneal organ, not only the surface, that is ongoing, as we identified a special scaffold that after deproteinization acquired the lamellar structure resembling the human cornea. And after, since the adhesion of the cells is required to avoid the stem cell loss, this kind of scaffold was chemically functionalized and colonized with epithelial and endothelial cells. The last results with endothelial cells is a very recent results, which is under patent now, reforming a corneal structure completely transparent and able to restore even more deep lesion in patients suffering from this pathology. And in addition, the reconstruction of airways, which is something brand new that I'm going to show, the manuscript is in preparation, where the idea was to rebuild part of the nose, which are missing in, for example, empty nose patient or the trachea, by reconstructing airway epithelium and cartilage. And you can see here the picture of mature cartilage reconstructed in vitro on a scaffold identified for this body area, as well as the capability to obtain the airway epithelium with very long proliferation rate and the presence of all differentiation lineages such as secretory cells, goblet cells, and ciliated cells needed for the normal airway function. So in conclusion, the routine clinical application is possible and human tissue models are available as the animal model are going to be progressively replaced by human models and organ on chip. The research can achieve amazing results. Now we need a business model linking the two areas in order to provide a routine clinical application for all the patients that needs the amazing results that can be achieved by these technologies. I want just to remember some of the many people that were working together with us, as this is a multidisciplinary team work, especially in the skin field for burn. I want to remember particularly Rosario Ranno and Giorgio Stracuzzi of Catania Burn Center and Francis Planinšek in Ljubljana, as well as Paolo Rama, Augusto Pocobelli, Carlo Enrico Traverso for the eye and ocular, the corneal reconstruction, and Giuseppe Romagnoli, Guido Barbagli, and Gian Antonio Manzoni for the urethral reconstruction, and the people from the lab working on these results, as Davide Adamo and Giulia Galaverni for the airway, Federica Magrelli and Rosa Estecchi for the 3D cornea, as well as Ivan Martin, Ranieri Canceda, and Andrea Barbero for the cartilage of the airway. Thank you for your attention.
I was wondering, these epithelial cells, in particular the limbal cells, the stem cells, can you derive them from ES cells or iPS cells?
There are several studies reporting the generation of limbal corneal epithelium and limbal cells from iPS cells particularly. Still, the reproduced cornea is not identical to the natural one, but the first transplant were done in Japan by Koji Nishida, and we will see the long-term follow-up, how it works.
Désiré Colin?
In order to use cultured epithelial cells, autologous, in a patient with extensive burns, you must get the cells from the patient, since they're autologous, and you must culture them, which takes time. What is the timelines between an acute extensive burn and the time that you can apply skin transplant autologous to that patient? Is that a day, a week, a month, probably somewhere?
No, I can tell you, sorry, I reduced the audio, otherwise there is echo. I can talk about the last generation technology, as this is, I think, the golden standard at the moment. The biopsy taken from the patient should be between 5 and 7 centimeters square, which is usually available even in extensive burn, as under the axilla or under the feet, some skin is still remaining. With the 5-7 centimeters square, it's possible to rebuild 1.8 square meter of skin. The timeline is defined as in the following way. The biopsy should be taken in the first days, just as soon as possible to avoid contamination, and the patient should undergo a sclerectomy and a coverage with allogeneic epidermis, full dermis, with the dermis and epidermis, in order to have the coverage of the surface in the window where the patient are spontaneously immunosuppressed by the burn. Then, in the time, the immunologic system usually needs between 3-4 weeks to start again to react against allogeneic components. In that time, which is 3 weeks, we are able to rebuild the whole body surface, and then by dermotomy is cut the allogeneic epidermis, and the autologous epidermis is transplanted over the dermis. In this way, the dermis is accepted and not rejected, whereas the epithelia is strongly antigenic. I don't know if it's clear what I explained. Tell me if I answered your question.
Thank you. Is there a last question for Graziella? Well, if not, thank you very much again, Graziella.
Thank
you. So as I said, Graziella Pellegrini shared the Jeantet Colin Prize for Translational Medicine in 2020, together with Michele and Luca, who is the next speaker. We'll also, hello, Michele, can you hear us? Excellent.
Yes.
Michele got his MD in Catania, and then became a specialized endocrinologist in Roma. Then he went to the NIH in Bethesda before moving to Harvard Medical School. Michele De Luca now is at the Center for Regenerative Medicine in Modena, in Reggio Emilia. As I already mentioned for Graziella, Michele is an expert in regenerative therapies by using epithelial stem cells in patients suffering from acute ocular and skin disease, as we just heard. And once again, together with Graziella, Pellegrini, Michele won the Louis-Jeantet Prize in 2020. Michele, please.
Yes, can you hear me? Okay. Okay, thank you. Thank you. I apologize for not being there. Number of reasons. I can hear an echo though. Do you hear me well? Okay, well, okay. So I'm going to speak about combined cell and gene therapy for epidermolysis. Those are colonies of keratinocytes, epidermal keratinocytes that are grown on the thinner layer. As Graziella was mentioned, they eventually diffuse and they will give rise to a crazy sheet of epithelium that can be grown on filamen and then applied on patient. And already Graziella mentioned about the use of these epidermis for the treatment of this burn for many, many years. And she was mentioning about the regeneration of the ocular nerves. So it was sort of natural to think about the identification of those epidermis cells to address the problem of therapy. And we have a devastating skin disease that is called epidermolysis or hematophage syndrome. Our epidermis is attached to the underlying dermis structures, which are called epidermis. And there's a chain of proteins starting from the basal keratin, keratin 5 and 14, get in touch with the integrin 6 beta 4 and the laminin 5 or laminin 6, which is that get in touch with collagen 7 in the body. So this is the chain of proteins that keep our skin together. Of course, we have mutations in the genes coding for each of these proteins. And we have three main forms of epidermolysis bullosa. Simplex, where we have mutations in the 5 and 14. But the most severe forms are the junctional and the dystrophic. In the junctional, the blister is within the basal lamina, while in the dystrophic, the blister is beneath the basal lamina in the superficial dermis. You will see how important it is for the proper treatment. These kids, they develop blisters, tremendous blisters, from birth upon minimal trauma. So they have a really poor quality of life. About 40% of the patients with the severe junction will be die for the age of 8. And in any case, those people, those patients that reach adulthood, both in the junction and dystrophy, they develop quite aggressive squamous cell carcinoma. So they have a short life. Being a genetic disease, obviously, the only possibility is to fix the gene defect. And many, many years ago, we started phase 1, phase 2 clinical trial by using epidermal stem cell genetically modified with a retroviral vectors, carrying, in this case, one of the components of the laminin 5, LAMB3 synthetase. patients suffering from a severe form of functionality. And we transplanted the upper legs. And you see that this paper was published in 2006. Now this patient has over 50 years, almost 17 years follow-up, and newly formed epidermis, transgenic epidermis, is fixed. He doesn't have any blister. As you can see here, also in the long term, by in situ hybridization, you can see here that the epidermis is transgenic, and there is normal expression of lamellin 5. At that point, we stopped all our trial, including actually the cell therapy with the cornea, because there was a change of the regulation in Europe in 2007, where these advanced therapy medicinal products were considered medicine, so under the control of the European Medicine Agency and the state regulators like IFA, PEI, whatever. So the whole war changed. We have to make up a GMP facility, make the GMP certification, ask for all the authorization. And just to give you an idea, the whole process that goes from basic research or the first proof of concept to the real development of clinical trials and application is as complicated as is shown in this slide. So we basically lost about 9 years to accomplish all this regulation. And in 2015, we were able to reproduce in another patient in collaboration with John Bauer in Salzburg, this first proof of concept showing that transgenic epidermal cells can indeed regenerate a functional epidermis expressing normal level of the protein that is missing in those patients. And it was published in 2017. So in those days, we were ready to start again our phase 1 and phase 2 clinical trial. But something happened to us that changed completely our strategy. And what happened to us was the story of this kid, Hassan. He's a patient from Syria. Hassan was suffering from a quite severe mutations in the lambda-3 gene, one of the components of lamellin 5. And can you imagine a kid like this under the civil war, how a blistering disease can be treated? So the family moved to Lebanon. In Lebanon, they couldn't do anything to this kid. So throughout humanitarian organizations, they moved to Germany. But meanwhile, the kid has a super infection with Staphylococcus aureus, Pseudomonas aeruginosa. So he lost the skin. Instead of having the blisters come and go, he basically lost the skin. He was admitted to the birth center for getting development in Germany. They asked for help, and this kid did not meet any inclusion criteria, so he could not include it. So we asked the regulatory authorities for a compassionate to the German regulatory authorities. They agreed to do this. So the entire lab, the entire institute was concentrated in this month in doing this. We took about 4 centimeter squares in biopsy, make genetic correction in the retroviral vectors containing lambda-3 CNA, and prepare approximately 1 square meter of transgenic epidermis that we then transplanted together with a surgeon in Bochum in 2015. From a surgical point of view, it's not very difficult because you have to repair the wound bed to clean it up. And it's a situation completely different from the burn, because in the burn, you don't have any dermis. In these patients, you have a dermis, which is the ideal receiving bed for any epidermal culture. And I'm going to go very fast on this. This is the first transplantation we did for limbs. It's the left arm, you see the grafts, and at the removal of the vaseline gauze, you see the newly formed epidermis underneath the gauze. And this is by 1 month, the left arm was covered by the epidermis. This is the left leg, 10 days, 1 month, we formed epidermis. This is the right leg. 1 month is fully formed epidermis. So 1 month later, we went back to the remaining part of the body. And this was the devastating situation of Hasan back and flanks. But the preparation of the wound bed by the surgeon was done quite properly. As you can see here, there is this white matter here, the receiving dermis, which again is the ideal receiving bed for the grafts. And by 1 month, almost entirely, the back of Hasan was covered by skin. You see that we did not have a good take in the buttocks. And this is something that we usually observe also in the burn. But you see these islands of keratinocytes and the age. So we just let the cells do their job by changing medication. And you see by 4 months, the entire back of Hasan was covered of skin. So the bottom line of the story, obviously, the prognosis of Hasan at admission was very poor. They did not expect at all for this kid to live. But 2 days before Christmas, he was out of the induced coma. He was in induced coma for 5 months. He was discharged from the hospital 2 months later in February 2016. This is the visit he did in Modena for a follow-up visit in 2017. And you see that by 1 year later, basically his entire epidermis was covered by newly formed skin. Hasan is now back to virtually a normal life. We still have about 20% of his body that has still blisters because we transplanted 80% of the body surface. But you see, this is 3 years follow-up. This is 5 years follow-up. And for the skin, 5 years follow-up is a tremendously long period because we change our epidermis basically every 2 or 3 months, as I will show you this. So there is a constant renewal of the epidermis, and the stability of the transgenic skin at 5 years is really, let us think that the skin has been fixed basically forever. As a matter of fact, we just published a few months ago the long-term follow-up, and you see the more we go, the better the skin looks in this patient. The epidermis is transgenic. Every single biopsy we took, and we took many biopsies from his body, by in situ polarization, you see that there is entirely transgenic. This is the absence of laminin 5 at admission. This is how laminin 5 is supposed to be in a normal human being. And this is the restoration of complete normal amount and normal distribution of laminin 5 at the dermal-epidermal junction. And also by transmission electron microscopy, the number, structure, and function of the hemidesmosome must be completely restored. This is the reason why in those 5 years, Hasan did not develop a single blister in the transplanted area. He has normal wound healing upon injury. He had no adverse event. He had no pain, no itch, that are one of the most severe symptoms also in these patients, besides the blisters. He has normal mechanosection and nocisection. As a matter of fact, we analyze every single parameters you can imagine in the skin. We have normal expression of the involucrin, which is a differentiation marker, or keratin 10. We have normal expression at the right position of keratin 14 that stains the basal layer of the epidermis. We have the presence of Langerhans cells, melanocytes, metals, P63, all the parameters are back to normal. The only difference we saw was a little bit of dyschromia. I don't have the time to go into this, to the reason for the dyschromia, and a decreased amount of elastin fiber. That does not depend on the graft, though. It depends on the years of inflammation that he had in his skin. But this was the only difference if we compare normal skin with the newly formed transgenic epidermis. As a matter of fact, Hasan was extremely useful because we learned a lot from him. And we learned a lot from him because if you think about, we have a transgenic tissue now that you usually you do not have beside the blood. And so we were able to analyze and learn something about the biology of the epidermis. You see, there was still some debate in the literature whether the mammalian epidermis were sustained by a single population of progenitors that stochastically give rise to differentiated cells, or exactly as it happens in the hematopoietic system, you have a sort of hierarchical type of organization of the chronogenic cells, starting from long-lived stem cells to short-lived progenitors to differentiated cells. There was still a little bit of debate. But now we have the possibility of analyze this in deep because of the transgenic scheme. As a matter of fact, we can clone, we can analyze chronogenic cells at a single cell level. You take a single chronogenic cells, you generate a single clone. And then you can analyze those clones by plating 1/4 of this clone in what is called indicator dish. Now, this clone, they have disappeared. You have growing colonies like this and aborted colonies. When you plate indicator dish by evaluating the number of you can divide those clones in 3 types: autoclones, metaclones, and paraclones, based on the percentage of aborted colonies. The autoclones have the lowest percentage of aborted colonies, usually close to 0, and they have a tremendous proliferative capacity. The problem is that you cannot distinguish holoclones from metaclones. You can distinguish the aborted colonies, but you can distinguish holoclones from metaclones. As a matter of fact, the clone size is virtually identical. And it took many years, Graziella was mentioning this, it took many years to try to identify at the molecular level those clones. And one of the key transcription factors being delta and p63 alpha, that the knockout of p63, it caused a lack of all stratified epithelia. Based on this, which will be showing that the level of expression of p63 alpha is very high in holoclones and progressively decreased during clonal conversion. Another piece of observation that Graziella was mentioning to see whether those are stem cells and those are transient progenitors, as this data would suggest, is indirect evidence that comes from the corneal restoration, where you have a success of the corneal regeneration only if you have a precise number of p63 bright holoclones. And the moment you go below this number, you have a drop on the success rate. But this is an indirect evidence. It's not a formal proof that the holoclones are the stem cells. But now we have a transgenic scheme. So as I was mentioning you, those cells, they grow in colonies. The moment we transduce this, we infect this with the retroviral vectors, the retroviral vectors gets integrated into specific random area of the genome. So we can exactly know for each chronogenic cells by cloning the integration site exactly where the transgene is. So in other words, when we play these transgenic cells in culture, each of these colonies has a color, has a sort of mark that we can follow during time. And all these chronogenic cells, they are the ones that make up the graft that we put on the patient. And if we analyze this graft before transplantation, we can determine the number of, by single cell analysis, obviously, as I told you, we can grow the cells at the clonal level. We can determine the number of holoclones, metaclones, and paraclones that are contained in the graft that we are putting in the patient. The difference now is that those holoclones, metaclones, and paraclones, they have a color now that can be identified. So when we take this graft and we transplant in the patient, and then we took new biopsy later, we could show that we have a switch toward a sort of monoclonality. So only few chronogenic cells will remain for a long time. And how can we show this? We show this by taking biopsy in the long term, like 4 months, 8 months, analyze those regenerated skin at the clonal level, again with clonal analysis, tremendous experiment. And this time, we do have holoclone, meroclone, and paraclone. As you can see here, uniform meroclone and paraclone, they have the same integration of the founder holoclone. And the integration of this in the founder holoclone is the same integration found in the holoclone before grafting. So in other words, during time, we lose meroclone and paraclone, we have stability of the presence of the holoclones. Those holoclones, they continuously generate new meroclone in the paraclone. So we could now formally do that the human epidermis is sustained by a population of long-lived stem cells that generate short-lived proteins, and they generate differentiated cells. And now we can formally identify those long-lived stem cells as holoclone-forming cells, and the short-lived proteins as meroclone and paraclone cells. I told you at the beginning that these patients were changing the strategy because with all this data in our hands, we went to ENA to ask for a protocol advice, and they allow us to avoid the phase 1, phase 2 clinical trial. And we just started. This is one of the reasons why I couldn't move, because we already started 2 patients last week, or 10 days ago, of a multi-center European phase 3 trial, which is a pivotal trial, that if it works, it will be approval of this therapy. And I just want to thank all the people that were involved in this work, inside the lab, and Graziella, and also the surgeons, pediatricians, and all the people that were helping us in analyzing the integration site. In the last 4 or 5 weeks, I'm going to show you some unpublished data. I keep going on this. And in collaboration with John Bauer, try to tackle recessive dystrophy, a different gene. We did a phase 1 and phase 2 clinical trial using the same procedure by changing the gene collagen 7. And now the problem starts. Because at the 1-year follow-up, we have a mosaic expression in the newly formed epidermis, positive and negative area. And if we do laser capture crystal analysis, underneath the positive area, we have the drug gene, underneath the negative area is the contrast gene. So the patient refers to a smaller blister that heals faster, but it's not enough for a complex things like gene therapy. We have to have the same results as we have injectional. So we try to understand why this was happening. And to make a long story short, very long story short, we thought that there was a competition between the cells in dystrophy and injunctional. Why? Because injunctional EB, you have the blister that detach the epidermis from the basal layer, but not in the dystrophy. And the adhesion is very important to keep the epidermal stem cells. So what we thought is that the reason why we had this problem in dystrophy is that the transgenic junctional EB, they had a selective advantage onto the cells from the patient. So they were substituting all the epidermis, but this was not happening in the collagen 7. And we understood why. This has to do with 2 pathways. One is the YAP-TAZ pathway, because the interaction between laminin 5 and alpha-6 metaphor integrin is important to get YAP into the nucleus, and YAP is crucial to maintain epidermal stem cells. So in the absence of laminin 5, we have an epidermal stem loss because YAP is in the cytoplasm. This happened in junctional, but not in dystrophic. And we went on this by doing a single-cell transcriptomic analysis and show that downstream of YAP, there is another transcription factor, FOXM1, the ablation of which abolish monoclones, but not monoclones and paraclones. So in other words, laminin 5 alpha 6 beta 4 integrin activate FOX and keep epidermal stimulus. This pathway is disrupted in junctional, but not dystrophic. This is why dystrophic were competitive. So we went back and analyzed at the clonal level what we were applying onto our patient. The efficiency of transduction with retroviral vector was 75%. But if we analyze transduction in the clonal culture, about 50% of the clonogenic cells, they have full-length collagen stem. So in other words, we were putting on the patients a graph that were containing only 50% of the genetically correct cells. And this is why we have mosaic. So we stopped the trial. We designed a new vector. This time is a single molecular vector that is increasing the efficiency to over 95%. We changed the procedure of transduction by making 2 runs of infection. And obviously now, at least we can show at the clonal level that every single clonogenic cell has at least 1 full-length collagen cell. So with this in mind now, we are almost ready to submit this within November, hopefully. We should submit a phase 1, phase 2 clinical trial using this new gamma retroviral vector to avoid cell competition. And obviously, during these 2 years, we had to do all the procedure and the regulatory pathway validation and everything that I showed you before, again, with the tremendous amount of money and time to accomplish to the regulations in order to start the phase 1 and phase 2 clinical trial. I don't need the time to mention the new things that we are doing for the dominant form of epidermolysis bullosa, where we are developing a new strategy for CRISPR-Cas9 gene editing. Obviously, we have to do this because in the simplex form, the mutations are dominant. And we also started a new project trying to address with a single platform another genetic disease called lamellar ichthyosis. But I don't have the time going into this. I just want to take the small group of people actually that precisely, specifically are involved in the Center for Genetic Medicine for the development of all these gene therapy strategies, and obviously all the clinicians that are involved in those clinical trials. John Bauer in Austria, Christine Bodemer in Paris, Christina Haas and Olb Schneider in Germany, and Cristina Magnoni and Chiara Fiorentini here in Modena. And I thank you for the attention. I don't know whether I had a very terrible echo when I was speaking, so I don't know if you were able to follow me properly. Thank you.
Thank you very much, Michele. Thank you. Very interesting to see how translational medicine can take us back to basic research, actually. Any questions?
Did you have echoes where I was talking?
No, it's okay.
Okay.
Question there.
About the reconstruction of after epidermolysis, you mentioned that there was some dyschromia of the new skin. And my question is this, the protection against UV light should be lacking. What about the melanocytes in your grafts?
Well, you know, as Graziella was mentioning, when we grow this graft, we do have melanocytes. But the culture conditions in the vitiligo are optimized to have the proper number of melanocytes. In this case, we have to optimize for the growing colonies. So there is a sort of not homogeneous distribution of the melanocytes in the graft. On the top of this, the back of the patient, the area where we did the second operation, was done also with to start with. This procedure is not very good for melanocytes. So this could be coming from this homogeneous distribution of the melanocytes. What we are noticing though, the more the time goes, and the better is of the expansion of the pigment. On the other hand, this patient does not expose himself to the sun anyway. But that's the best we could do for this patient.
Mike Hall.
Just a small question. I'm wondering whether you need immunosuppression to prevent rejection of the transgenic epidermis.
First of all, the epidermis is autologous because obviously we do cortisone tests. I didn't have the time to go into it, obviously, but we did all the immunological tests, both in this first patient, the second patient, third patient, and we never observed any reaction against the transgene. As a matter of fact, when we do the selection of the patient, we try to select patients that will still have a little bit of expression of laminin 5. And this was also seen in Sahin. Up to now, not with any patients where we have the complete double knockout of the gene with total absence of any expression of the protein. It's something that we should address at the right moment. So no reaction up to now. Not in functional and not in dystrophic.
Any more questions? Yeah, Daniel. Oh, the question from Daniel and then Desiree.
Thank you very much. Are tumorigenic mutations in these stem cell grafts a concern for quality control? You know, potentially tumorigenic mutations. Is that? Do you screen for those?
No, this is a very important question. I need a couple of minutes to answer this. The insertional mutagenesis is an issue that is being shown specifically in the hematopoietic system with the retroviral vectors. Not in all cases. For instance, the adenosine deaminase immunodeficiency has no insertional mutagenesis. In these patients, we are transplanting something like close to 10 to the 9 chromogenic cells. We have a follow-up of 5 years to 17 years. No clonal expansion has been. We are analyzing all the information sites all the time. There is a paper that is under submission right now to analyze all the problems, potential problems. As a matter of fact, in the last 30 years, we have used those cells in vitro with a number of transgenes, and we never observed any clonal evolution, any clonal growth that could lead to transformation or even immortalization. So it doesn't seem to be an issue for dekeratinocytes with this vector. On the top of this, you see that the skin is superficial, so you can see exactly what they are doing transplanted. These patients, they invariably develop squamous cell carcinoma during the time. So for this amount of data we had of observation, as a matter of fact, I think we are actually decreasing the risk of developing squamous cell carcinoma in this patient. If we treat this patient fast enough, it fixes all the additional questions.
Desiree?
The boy Hassan, after his full recovery, his face and his scalp looked almost normal. Was his head also skin transplanted, or was that less affected?
No. This is quite an interesting issue of this disease. They have the penetrance of the disease. I tell you the case of two siblings that they have the same mutations and they have two different phenotypes. We have patients where you have blisters only in some part of the body. You have patients with generalized blistering with similar mutations. In the case of Hassan, he doesn't have much blister in the scalp except in the back. The back is no hair, actually, and except in the face, where you have only two blisters in the front head. And it doesn't have blisters, for instance, in the head or in the feet, but all over the body. It's quite normal to observe this in TV.
Well, thank you very much, Michele. Thank you. So we're quite on time to go for a coffee break now. Let's perhaps come back at 11:05. I'm very glad that Diane Mattis from Harvard Medical School and the Broad Institute will be chairing the next morning session.
This session is devoted to the 2021 laureates. And our first speaker is Jérôme Galon, who's sharing the Louis-Jeantet Prize for Translational Medicine for developing technologies which are used to study the progression, the role of the immune system in the progression of cancer and thereby improving cancer diagnosis and treatment. Jérôme is currently the director of the Laboratory of Integrative Cancer Immunology, an INSERM laboratory, and his title is the Immune Contexture and Immunoscore in the Era of Cancer Immunotherapy. Thank you.
Thank you, and thank you for the introduction. So I will define what we have called the immune contexture and immunoscore. So when we started working on cancer, I didn't want to focus on a particular molecule. I had no favorite cells, but really we wanted to try to address the complexity of cancer, trying to understand not only cancer cells, but also the tumor immune microenvironment. And we used the new technologies at the time, the genomics and also the immunomics, and did systems immunology in order to have an integrative view of cancer in human patients. And if we go back to when we really started, which was in the year 2000, the famous hallmarks of cancer review just came out, putting all this in this comprehensive review, basically all the key aspects of cancer. And at the time, there was not a single word about the immune system. And so, as you probably know, cancer is a disease that is caused by mutations that is progressing from normal tissue to a carcinoma with a progression within the primary organ, the T stage, the evolution in the primary tumors with increases in size and in depth, so T1, T2, T3, T4. There's different parameters associated with the aggressiveness of cancer and cancer cells, the mutations, the chromosomal instability, the microsatellite instability. And then there is tumor invasion with node invasion and distant metastasis. And then there's recurrence of cancer if a cancer is removed by surgery. And basically the tumor aggression and progression and invasion is the TNM staging system, tumor node metastasis, really define what is considered an early stage cancer versus a late stage cancer. And it's also based on that the severity of the disease is defined and therapy is given. What we found is that, in fact, there are key parameters that are different. That is, in fact, the immune system of the patients. And we define these key parameters as the immune contexture. And in fact, what we found was that all the parameters of cancers, tumor progression, tumor invasion, recurrence, are all dependent upon the pre-existing immunity of the patients. In fact, the fate of the tumor cells is dependent upon the pre-existing immunity of the patients. And in fact, the pre-existing immunity is determining the likelihood of survival of the patients. And also now that we have efficient therapies and immunotherapies, this pre-existing immunity is also determining the likelihood of response to these immunotherapies. And so these immunotherapies really came into the oncology field, and it was actually the breakthrough of the year for science in 2013, because there was a very different aspect of the survival of the patients following immunotherapy. In the past, all the previous therapies like targeted therapy, chemotherapies, the impact of the drug was evaluated as the difference in the median survival of the patients. So basically the red curve versus the black curve. And seeing that difference in months or even few weeks was enough to get a drug approved. What happened with immunotherapy was that now you are not targeting the tumor cells. You're not trying to kill the tumor cells. You are trying to reboost the immune system. And by doing so, and because the immune system has, in particular, a memory capacity and an adaptive immunity aspect, now we have not only responders, but also long-term responders. And as you can see from these survival curves, now there are patients here, the green patients, that following immunotherapies now are surviving, and even some of them may be cured. And nowadays, combination immunotherapy is given, and there is an improvement, but still there are these blue arrows here where you can see that many patients are in fact relapsing and dying, even though they are receiving these types of treatment, and we should do better for these patients. So back in 2006, we put the foundation for this concept of the immune contexture. And in fact, in this paper, we define the immune contexture parameters as the parameter being associated with the survival of the patients. And they consist in 4 different parameters. The types of immune cells that are important within the tumors, the density, so a notion of a quantitative notion, the density of these immune cells. The location, so the spatial information is important. And in fact, with these 3 first parameters, we defined a test that we call immunoscore, that I will describe in a minute. And the 4th parameter is basically an immune functional orientation of the response, which is the quality of the immune response. And these are the 4 immune parameters that defines the immune contexture. And I will come back to this immunosign, that is a signature measuring the quality of the immune response, and to the immunoscore, and especially in the context of CAR T cells, actually, and immunoscore. So what we found was that, in fact, when you look at large cohorts of patients and stratify the patients according to the immunoscore, which is the measure of the densities of cytotoxic T cells in specific areas of the tumor, in the center of the tumor, and also at the invasive margin of the tumor, the patients having a high immunoscore, which has these inflamed tumors, these strong pre-existing adaptive immunity, these patients are surviving without recurrence for many years. As you can see, this is more than 10 years, 15 years follow-up. And this is happening, so when they have a high immunoscore, they are surviving and not relapsing, even though they have a late-stage tumor. You can see here the distinction between TNM stage 1, 2, and 3. It doesn't matter. And the same thing is for the low immunoscore patient, those who have a low non-inflamed tumors, weak or absence of pre-existing adaptive immunity. These patients will have a very rapid tumor recurrence. And this is happening also in very early stage patients. And so this coordinated adaptive immune reaction, as measured by immunoscore, now it's called immunoscore, more than the tumor invasion parameters, was really associated with the clinical outcome. And the novel paradigm came when we did the Cox multivariate analysis to test the strength of the parameter and the dependency of the parameter in a multivariate model. So not only immunoscore, so the evaluation of the pre-existing immunity of the patient is significant on the multivariate model, but beyond that, and even more strikingly and more importantly probably, all the other parameters are now no longer significant and are statistically dependent upon the pre-existing immunity of the patients, the T stage, the N stage, the grade of differentiation. And if you add other tumor parameters, they wouldn't be significant. And so we have these immune contextual parameters, the types measured by the different specific immune cells, and in particular adaptive immune cells, the quantitative notion with the density quantification, the spatial information with the location of these cells within the tumor, and the quality of the immune response, which is measuring the functional immune orientation of the response. And in fact, we discussed back in 2013 the fact that these specific immune contextual parameters not only are prognostic, so being associated with the survival independently of the treatment, but are also predictive of response to treatment that is impacting the immune response, and in particular immunotherapy, and are also mechanistic, which means that when a patient is responding, what is happening in the tumor is that the same immune parameters are increased. And so we have basically defined some of these important parameters, the types of T cells, cytotoxic T cells, the T helper type 1 T cells, some specific cytokines and chemokines, some B cells and TLS. And depending upon this intensity of the immune response, we can define predictive signatures, prognostic signatures, or mechanistic signatures. And we define this as a continuum of cancer surveillance, and we analyze that in the context of cancers, but not only cancers, also in the context of pre-cancer lesions. So what is happening before cancer? When the tissue starts to become abnormal, but not yet cancer, is the immune system sensing that? And we also analyzed it in the context of very late metastasis. Is it at some point the immune system overwhelmed, and is there an immune escape? And so I will describe a few of these studies. So first, the primary cancer. So what is happening in the immune microenvironment of primary cancers? We analyzed the spatio-temporal dynamics of the evolution of the immune response with the progression of cancer by analyzing large cohorts of patients at the different stages, T1, T2, T3, T4, to see what is the type of immune infiltration, what is the immune functional orientation at the different stages, and how this is changing with the changes in the tumor cells. And in fact, we did multiple types of technologies, and this is with RNA-based genomics, and this is actually quantification of immune cell types and immune cell subpopulations within the tumor microenvironment in specific areas in the center and at the invasive margin of the tumors, and looking at the densities of the cells of different types of immune cells, and we see some major cells, we see interactions between cells, we see correlations between cells with networks of all these adaptive immune cells, as you can see, memory cells, memory T cells, B cells, with subnetworks, with areas, the yellow, the invasive margin, the blue in the center, and some cells that are excluded from the network, like the granulocytes, the IL-17 producing T cells. And we can look at the impact of each of those cells on the survival. So now instead of plotting the density of these cells, we can look at the hazard ratio, so meaning the difference in survival associated with high or low densities of these cells. And so back in 2012, seeing that these cells were so important, we decided to initiate a worldwide consortium to try to validate and have a consensus on how to score and quantify these adaptive immune cells. So there were many centers in the world who wanted to participate. There was a lot of discussions and meetings for defining what should be the assay, for assay harmonization, so that each center would perform the same assay. And the results of the study were published in the Lancet in 2018 with this international validation of the consensus immunoscore for the classification of colon cancer. Just in one slide, the results were obtained. So basically validating all the primary endpoints, secondary endpoints were reached. This is looking at the contribution to the risk of the different parameters. On the left, you see the current way of staging patients. So the main parameters have the bigger part on the pie in terms of contribution to the risk. end stage, T stage, grade of differentiation, VLIP, which is venous emboli, lymphatic invasion, perineural invasion. On the right side, when you add immunoscore now, you can see that immunoscore represents half of the risk, taking over all the previous parameters. And in fact, in multivariate analysis, immunoscore in 2 groups, high or low, in 3 groups, because it is a quantitative measurement, so high, intermediate, low, or in 5 groups, immunoscore 0, 1, 2, 3, 4. All the p-values for immunoscore in multivariate are below 0.001, and all the other parameters are in fact dependent upon the pre-existing immunity of the patients. So we validated that in several cohorts, including randomized phase 3 clinical trials, and in particular in the stage 3 disease, because this is a disease where, a stage where chemotherapy is given and not efficient for all patients by far. And this is actually the immunoscore stratification with the 5 groups of immunoscore, immunoscore 0, 1, 2, 3, and 4. So 4 being very hot tumors, a lot of immune cells, adaptive immune cells, both in the center and invasive margin. Immunoscore 0 being the low immunoscore absence of cytotoxic T cells. And you can see the direct relationship between the immunoscore of a patient and the survival of a patient. And these are up to between 5 and 8 years follow-up in these different cohorts of patients. And you can see that even though we are on a very restricted population, these are all stage 3 patients, there's a drastic difference between patients, between immunoscore 0 and 4. And you can also notice that all the patients with an immunoscore 4 do not have a single recurrence or death in the 4 independent studies. This led to the first introduction for the first time of the immune response in the WHO book, immune response, and as measured by immunoscore being an essential and desirable diagnostic criteria for digestive tumors. This was followed in 2020 and 2021 by the inclusion into the European and Asian clinical practice guidelines for this evaluation, both for the prognostic value and the classification power of the immunoscore and for its predictive value of response to chemotherapy. And then we noticed during those studies that in fact, this strong adaptive immunity was at its best and the highest in terms of densities the earlier. So if you can see here, the T stage, T4, T3, T2, T1, T in situ. So the earliest tumors, the smallest tumors have the highest density and already a very strong adaptive immunity, which probably meant that there was already before cancer something about the alteration of the normal tissue that is not yet a cancer that led to this strong adaptive immune response. And so we analyzed precancer lesions, and what is best to analyze precancer lesions than to take heavy smokers. So we took heavy smokers at risk of developing cancer. And we had so we had bronchoscopy of the lung from heavy smokers, and some of them had normal lung, some of them had precancer lesions in the lung, like hyperplasia, metaplasia, mild dysplasia, moderate dysplasia, and some of them are already cancers, squamous cell carcinoma. And so we analyzed those lesions to see when and where and how the immune system is sensing that something is happening in these tissues. And we had this paper, Immune Evasion Before Tumor Invasion in Early Lung Squamous Carcinoma, where we basically found different patterns of gene expression. So these are all the developmental stages from normal to cancer with all the precancer stages with different patterns of genes. And you can see that there is a clear pattern that is associated with the immune pattern, that is this pattern of ascending in high-grade dysplasia. In fact, the first thing that is happening in terms of the immune microenvironment is already happening in low-grade dysplasia. So very, very early on, there is an immune sensing and an activation of the resident immune cells. This is followed in high-grade dysplasia by the full-blown activation of both the adaptive immune system and the innate immune system, and both at the same time of an activation and also immune evasion or escape as measured by immunosuppressive cytokines or checkpoint receptors being already upregulated at that stage. So the immune system is sensing very early on, but we know that cancer is progressing ultimately to metastasis. So is there an immune escape at some point? And is the immune system overwhelmed? So we analyzed a lot of metastases from patients. We analyzed here, in that particular study, different types of metastases, all coming from the same primary tumor. So colorectal cancer, primary tumor, leading to different types of metastases, liver or lung metastases. And these metastases were resected. So we could analyze the immune microenvironment in each of the metastases. And in fact, in these more than 600 metastases, we analyzed multiple immune parameters and also the immunoscore as defined by the consensus immunoscore, but done on the metastasis instead of the primary tumors. Just to mention, because Ton will also talk about specificity of the T cells, in some of these studies, we analyzed the specificity of the T cells against specific types of mutations that are the frameshift mutations. The frameshift mutations are very immunogenic because of the frameshift, and this is happening very often in a very particular group of patients that are the macrosatellite unstable patients. They have that characteristic of having a DNA mismatch repair deficiency, and therefore they cannot repair mutations. And in particular, they cannot repair the frameshift mutations. And therefore, they have a lot of frameshift mutations, which can be immunogenic. And in fact, when we analyze the MSI patients, having specific frameshift mutations that we can predict, in fact, we were able to detect specific T cells that were able to kill in this chromium assay the tumor cells in a specific fashion, in the specific context of the proper HLA of the patients. And this was not the case with a control peptide, or this was not the case for an MSS patients not having the frameshift mutations. So this shows that there are T cells that are specific, and we did that not only for this particular frameshift mutation, but also for others. And so we analyzed deeply the metastasis and look at some of the possible escape mechanism and look whether this was compatible with the current theories of cancer evolution. And just as a reminder for those who are not in the field, there are 4 theories of cancer evolution. There's 4 models. One is the linear model, saying that you need the accumulation of driver mutation, oncogenic mutations, for dissemination and for tumor evolution, with a selection of those driver mutations. The neutral model is saying that there are plenty of mutations that are not selected and that the tumor cells will evolve anyway with no particular selection of driver mutations. The Big Bang model, in contrast, is saying that you need first the accumulation of many oncogenic mutations and driver mutations before dissemination can occur. And finally, the branch model, that is probably the most accepted, is that there can be different types of driver mutations in different tumor cells that can evolve in parallel. But the common thing between these 4 models is that none of them is involving a Darwinian selection of those mutations and a possible immune pressure. And so we analyzed in human whether these theories, which are very tumor cell-centric, were valid, or if there was a role for the immune system in the evolution of tumor cells. And so we put this paper, Evolution of Metastasis in Space and Time is Under Immune Selection, in which we, to do that in human, because this has been done in mouse, to do that in human, we took patients that had not only primary tumors, of course, synchronous metastases and multiple synchronous metastases, but also multiple metachronous metastases and recurrence that would happen years after years after years. And we had follow-up for more than 11 years. And because we had all those multiple metastases, we could follow the tumor cell clones in each of the metastases and follow the immune reaction in each of these metastases. And so we analyzed that, and in fact, when we look at not only we did the phylogenetic tree of the mutation, so what are the tumor clones that are going from the primary tumor to a metastasis and then to a second metastasis, but also did this evolvogram, so how these tumor clones are evolving based on their patterns of mutations. And what you can see here, P1 is the primary tumor. You can see that the main clone is the blue clone in the primary tumor, and that this clone disappears. And in fact, is not the one that is leading and responsible for the metastasis. The one that is responsible for the metastasis is this purple subclone that is present in the primary tumor and transmitted to the first metastasis. But already in the first metastasis, it's not the major clone anymore. There is a new orange clone with a green subclone inside it that is the major clone. And as you can see, the green subclone disappears and is only present in that metastasis and not in the consecutive ones. Whereas the orange one is in the next metastasis, disappears, and then reappears. And so we can follow that on different conditions. And in fact, what we found was there is a clonal evolution, and that in fact, the non-recurrent clones are immuno-edited, whereas the progressing clones are the ones that are immune privileged. So we analyzed the different types of metastases based on the immunoediting score. So immunoediting meaning deletion of immunogenic mutations compared to silent mutations. So the lower is the score, the more immunoediting there is, so meaning the more immunogenic mutations deleted there is. And versus the immunoscore, so the higher is the immunoscore, the better is the adaptive immune system. And you can see that for immunoediting to occur in the metastasis, a high immunoscore is necessary, but is not sufficient because you can have a high immunoscore with no immunoediting. So there must be something about, so you need to have this adaptive immunity, but it's not only the quantity of the adaptive immune cells that is important, and there must be additional immunosuppressive mechanism, which we analyze in these different groups. I have no time to discuss it, but there are in fact different immune escape mechanism and immunosuppressive mechanisms in place in these three different groups of metastases. And so we propose this parallel immune selection model in which there is a dynamic interaction of the tumor cells with the immune cells and with Darwinian selections of escape variants that lead to dissemination and that leads to different metastases with a multiverse of metastases. Each metastasis is different, both in terms of immune tumor cells, clonal tumor cells, and immune cells. So for response to immunotherapy, and here I'm citing Ton because this is his review in Science, there are predictive biomarkers of response to immunotherapy. I put them here, all of them as peripheral parameters and intra-tumor parameters. Some of these parameters are already FDA approved as companion diagnostic to predict response to therapies. This is the case for the tumor mutational load, the tumor mutational burden, the microsatellite instability, which is leading to more immunogenic mutations, and the PDL1 expression, which is one of the checkpoints that is measured to predict response. There are other types of parameters, like the immune cell infiltration that we can be measured by the consensus immunoscore, and the tumor sensitivity to immune effectors. And you can recognize maybe some of these that I discussed early on as being part of the immune contexture. And so I'd like to highlight, to finish this in the context of therapies. And so we proposed in this review not to perform therapies based on the cancer types, based on the indication, but rather based on signatures and immune parameters that are associated with different types of cancers. Is starting with first an evaluation of the immunoscore, like evaluation of the pre-existing immunity in terms of quantity, then in terms of quality, and then looking at the different immune pathways that are altered in order to propose a rationale for combination therapies. So we analyzed these metastases just to mention that, in fact, the evaluation of the adaptive immune cells in the metastasis is associated with the survival of the patient. So this is the case for this study in lung and liver metastasis coming from colorectal cancer. Here you can see stage 4 metastatic disease with patients having an immunoscore high here versus those who have an immunoscore low here. And you can see major differences. The 5-year survival is 70% for the patients who have a high immunoscore, and is only 20% for the ones who have a low immunoscore. We also took the worst case scenario of patients having a brain metastasis. So it's the opposite. There's not only one primary tumor, it's multiple types of primary tumor with the common characteristic of leading to brain metastasis. And we analyzed the brain mets of these patients and look at the immunoscore in the brain mets. And you can see there are T cells in the brain mets, and you can see here in white the high immunoscore patients, and in orange the low immunoscore patients. Again, you can see major survival difference, significant, between patients having a high adaptive immune response in their brain mets, and these are the ones who have, in fact, long-term survival. You can see here more than 5 years survival for patients having brain mets if they have a proper adaptive immunity. So in the context of therapy, I would just like to highlight a checkpoint combination therapy. So here we did another assay, which is a measure of the cytotoxic T cells together with the measure of the PD-L1 expression and the proximity of these cells. So the distance measurement between the PD-L1 positive cells to the CD8 positive cells in order to make categories of patients according to these two markers, which gives very distinct mechanistic groups. The study was first-line patients, phase 2, randomized, with more than 216 patients, with chemotherapy, bevacizumab, which is an anti-VEGF, plus or minus atezo, which is the anti-PD-L1 immunotherapy treatment. So it's a combination immunotherapy versus what is in fact the standard of care here. The patients, so here we have 4 curves, the patients who have this high immunoscore IC population, which represent 32% of the patients, including in the MSS populations. And these are, in fact, the ones, as you can see, who are very significantly benefiting from receiving this combination of immunotherapy compared to the control arm, that is the yellow arm. And the dotted lines are the patients who do not have an immunoscore IC high, so which have a weak pre-existing immunity. Those do not respond to the combination of immunotherapy. So in fact, even in colorectal cancer patients, there are combo of immunotherapies that can be very efficient in a large proportion of the populations if these patients have a proper pre-existing immunity. Lastly, I'd like to discuss this in the context of CAR T cells. So these are the classical CAR T cells, CD19, in the context of DLBCL, so a diffuse large B-cell lymphoma, with the construct CD19 extracellular domain and CD3 zeta CD28 CARs. These CARs have been approved, and this is actually the article that led to the approval of these CARs. As you can see, the complete responders here versus those who have a partial response or no response here, with a very high rate of response in these patients. But in fact, to improve CAR T-cell therapy, of course, you can improve the CAR construct, you can get better intracellular signaling domains, and this has been done with first, second, third generations of CARs, better targets, dual targets, inducible CARs, so modifying the construct. But in fact, this is ignoring the fact that even for CAR T-cells, the tumor cells is not in the test tube, the tumor cells are present in the patient, and the CAR T-cells are probably not working alone. And so we did a very massive analysis of multiple samples pre and post CAR T-cell infusion. And just to briefly mention, because this has been recently published in Nature Medicine, this is the pre-existing evaluation, so pre-infusion of the CAR T-cells of the classical immunoscore, so basically the measure of the cytotoxic T-cells, and the immunosign being this quality evaluation with the adaptive immune signature. And in fact, these are patients receiving CAR T-cells, and you can see that their likelihood of response and the survival is very different based on the pre-existing immunity and the patients who are responding and benefiting from CAR T-cells in the context of DLBCL patients. Third line in that setting, that was the third line DLBCL in the ZUMA. one study, clinical trial, are the ones who have a high pre-existing immunity. And so not only the fitness of the T cells, not only the construct is important, the expansion of the construct is important, also the pre-treatment tumor burden is important, but also the pre-treatment, pre-existing immunity and immune microenvironment is essential for CAR T cell to be efficient. And finally, so we have our immune view of cancer. So here are all these concentric circles are different cancer types. For example, colorectal cancer at the outer circle, then breast cancer, etc. And this is a meta-analysis, in fact, of the immune cells. And you can see different pies, CD8 T cells here, M2 type macrophages here. And you can see that there are common patterns based on the densities of the immune cells that are either good cells or bad cells. And this is happening basically for many of the cells, many of the immune cells, regardless of the type of cancer. And with that, I'd like to thank all the people in the lab, of course, all the clinicians that were involved, our sponsors, and thank all the centers in the world who participated into the validation of the Immunoscore. Thank you.
So we have time for some questions. Yes, Tom?
With respect to your final observation around the CAR T cells that pre-existing immunity contributes to response, I guess there are two explanations. One is those pre-existing immune cells contribute to tumor control, or that this is an indicator of a tumor microenvironment that is resistant to T cell activity, T cell function. Do you favor one or the other explanation?
I think it's a very intricate aspect, and in fact, I think the pre-existing immunity is important for CAR T cells to reach the tumor, to expand. There is also a role for bystander T cells in the control of the tumor. Not only the CAR T cells are important in the killing, but they are also held by the others. Also, one important aspect is that the better is the pre-existing immunity, probably the better is the likelihood of having a good construct, or not a construct, a good T cells to be infused later on by the construct, because you are using the same T cells from the patient. So if you have a poor guy that has a weak immunity, and probably the generation of the CAR T cells with these T cells, his T cells that will be reinfused is probably of better quality. So I think all of that is playing a role into the final outcome of the patient. Yes. So yeah, I will repeat the question, sorry. So the question is Immunoscore predictive of a response to treatment, in particular immunotherapy treatment, and is Immunoscore evolving upon treatment? So the answer is yes. So I just showed you the Immunoscore IC, which is Immunoscore immune checkpoint, that is adding on top of the evaluation of the cytotoxic T cells, the PD-L1 component. We also have data, but they are not yet published, about the Immunoscore without PD-L1 that is also very efficient. The consensus Immunoscore is measuring the cytotoxic T cells in the center and invasive margin. So based on that, we have some restrictions into the use because we need to have access to an invasive margin of the tumor, which is not always the case. So in some settings with the consensus Immunoscore, we cannot get it, we cannot get the information. So that's why we derived an Immunoscore for biopsy, that is where there's no need for the invasive margin. And in that case, it is also predictive in that particular randomized clinical trial of response to immunotherapy. And the other point is about the changes. Yes, we know that there are different drugs, including non-immunotherapy drugs, that are changing the immune microenvironment and that can change the Immunoscore post-treatment Some of the best changes that we have seen are, for example, for oncolytic peptides that can be injected directly into the tumor. There are massive infiltration with T cells and a massive change in the immunoscore post-treatment.
So I think we can take only 2 more questions, one here and one here.
Jérôme, wonderful to see how this further evolves. I have 2 questions. One question is with regard to the proportion of patients in stage 3 with the top immunoscore. I believe it's 5. Yeah. What is the percentage of all patients with a low immunoscore? That means not 5. And the second is another highly significant prognostic factor in colon cancer are circulating tumor cells. Do you have any correlation between presence of circulating tumor cells and immunoscore, which would be most likely the case? Yeah. And do you see any causal relationship?
So, for the proportion of immunoscore patients, so it depends whether you have 5 groups of immunoscore, or 3 groups of immunoscore, or 2 groups of immunoscore. It also depends at what stage you are looking at the immunoscore, because what I showed you is that the smallest or the earliest are the tumors, the higher is the density of T cells. And therefore, there is a better immune control at earlier stage of disease. So the proportion of patients being high immunoscore, or immunoscore 4, the highest immunoscore, is higher at earlier stage disease. And then when there is a decrease in the immunoscore, that gives the license for the tumor to progress. And we see much more tumors in stage 3, for example, with a lower immunoscore. So specifically to answer the question about the proportion in stage 3 population of the different immunoscore, it's about, in 2 categories, it's low immunoscore, high immunoscore is 1/3, 2/3. In 3 categories is 1/4, half, 1/4. And in 5 categories, the smallest populations are the extreme, so the immunoscore 0 and 4. But we can still detect those patients, even though it's a minor group of patients in terms of number, we can still detect them. And circulating tumor cells. So we published, that was actually a long time ago, in 2005, a New England Journal of Medicine article where we analyzed, so at that time there was no ctDNA, right? But what we looked at something that was a bit in the idea of ctDNA, which was the presence of tumor cells inside the blood vessels and the lymphatic vessels. So when there is presence of tumor cells in the blood vessels of the primary tumor, or inside the lymphatic vessels of the primary tumor, which the pathologists can see, they just look at the slides, see the lymphatic vessels, and if there is a tumor cells inside it, it is lymphatic invasion. And this means early dissemination of some tumor cells already, which is associated with, now that we know, increased ctDNA production. So at the time, our New England Journal of Medicine article was about the fact that effector memory T cells were preventing early dissemination and were preventing. So we haven't done a proper ctDNA testing yet, or just on few patients, or not on large cohorts of patients. We suspect that there is a link between the two. The other point that I'd like to make is that very likely ctDNA positivity is not enough to predict recurrence, because I believe that what is important is not the presence of ctDNA detected or the presence of tumor cells, is the likelihood of a tumor cells to establish in an organ and to develop. And this can be controlled by the immune system, we believe, by memory T cells in particular. So even though some patients may be ctDNA positive, I believe that some will be controlled and will not have recurrence because they have a good adaptive immunity and a lot of memory T cells, and some of them will not and will develop recurrence. So we have to have much larger cohorts of patients to really demonstrate that. But this is the idea.
Thank you.
Apart the lymphocyte phenotypes, is there any role for macrophages, M1 and M2 in your system?
So we analyze many types of immune cells, including the innate cells. The consensus immunoscore, we focused on the cells that were the strongest and the most associated with the survival of the patient. And those were the T cells, the CD4 and the CD8 T cells, basically. It doesn't mean that the macrophages are not important. They are very important as well for the immune microenvironment, and they are also predictive of the survival. The M2 are typically, and in many cancer types, associated with a poor outcome, and the M1 type, if we can measure these M1, M2 types based on some specific markers, are typically associated with a better outcome, including in colorectal cancer. Now, for routine clinical practice, we wanted to make it as simple as possible. So with 2 markers was already enough to get a very profound stratification of high-risk, low-risk patients. So there was no need to add additional cells, but we know that adding additional cells would have an impact, and we know that additional cells, including the M1, M2 macrophages, are playing a role in the survival of the patients.
Okay, thank you.
Thank you.
So our next speaker is Ton Schumacher, who is the co-recipient of the 2021 Jeantet Colin Prize for Translational Medicine for development of technologies, to study the role of the immune system in cancer progression and for the improvement of cancer diagnosis and treatment. Ton is currently a senior member at the Netherlands Cancer Institute and a principal investigator at the ONCODE Institute, as well as a professor of immunotechnology at Leiden University. And his topic is T-cell recognition of human cancer.
Thank you, Diane. Let me start by saying that it's a true honor and privilege to be here and to talk to you. And also that's a real pleasure to share this award with Jérôme, whose work I really admire. What we share is an interest in trying to dissect immune reactivity, immune recognition of cancer in the context of the human disease. And I titled my talk Found in Translation because over the years we've gone more and more interested in dissecting immune responses in the context of human disease, using that knowledge to then design novel forms of therapy. And this drawing by M.C. Escher, Dutch artist, sort of illustrates that this is a two-way process in which, on the one hand, you have the scientific understanding of immune recognition that drives development of novel therapies, but also the clinical progress in IO that drives a better understanding of how immune function in the human context works. So the idea really has been to try and identify clinically relevant questions, create novel technologies to answer these questions. I think we consider ourselves engineers a little bit more than immunologists, and then in some cases also hope to use these emerging insights to develop novel therapies. My domain here is really on the left, trying to increase our understanding and engineer technologies, and really the lab has relied in a great deal on very intensive collaborations with some of my colleagues, in particularly John Hahnen and Christian Blanc, and I'll be sharing some data that involve close collaborations with both John and Christian. And first I'll be talking about understanding and building on a form of T-cell therapy, TIL therapy, as originally pioneered by Steve Rosenberg. And then I'll switch to work we've been doing with Christian to try and increase the clinical activity of the immune check and blockade that Jérôme also referred to. So TIL therapy, a little bit of background, why this for us became an inspiration to work on and look at its activity and understand how it works. So Steve Rosenberg at the NCI has spent many years developing a therapy in which from a patient you resect a tumor lesion, you assume that the T cells that sit in those lesions are enriched for tumor reactivity without really knowing. Then you grow these T cells to very large numbers in the lab, and then you infuse those cells in numbers of 10 to the 10th, 10 to the 11th into the same patient. So really an autologous T cell product that you create. And that treatment then involves, in essence, three components. Well, first of all, the TIL, the tumor-infiltrating lymphocytes that you've expanded. But there's two additions. First, you condition the patient with cyclophosphamide fludarabine to, in essence, make room for the incoming T cells. And you treat the patient with a T cell growth factor, IL-2, to also support the cells. So, to give you a bit of a further indication of how this process looks in real life, this is one of a production in our GMP manufacturing facility, where here you see the tumor material that is used to start such a TIL production, initially in very small cell numbers. You have a few million T cells, then you let the cells grow out, you have a rapid expansion protocol, and then you end up truly with a bag of white blood cells. The bag really looks white, and those 10 to the 11 cells you then infuse into the patient. So based on the work from Steve, we decided that we wanted to set up an effort at the NKI to first of all determine the value of TIL therapy when testing in our facility, in our hands, but also use this as a starting point to then dissect this process, understand what's happening the moment you treat a patient with such a TIL product. First, and very gratifying, what we observed is, and very much in line with the data from Steve, that a fraction of patients shows very profound clinical responses upon such TIL therapy. This is a patient where you here look at the upper leg, where you see here subcutaneous metastasis of his melanoma. This is prior to TIL therapy, and what you then see is within the first weeks after infusion of this autologous T cell product, massive necrosis starts to occur. After 8 weeks, in essence, no viable tumor material is left. And after 20 weeks, you only have scar tissue remaining. And this patient is now, I think, 8 years out and still a complete responder. So this really illustrates that TIL can be very active in at least part of the patient. I'll come back to that. But one major question that we've been trying to answer is, what is the active ingredient in TIL therapy? You could say, well, TIL therapy is a white bag, but in essence, it's also a black box. You're infusing an undefined cell product. And what we wanted to do is try and understand what the T cells in those cell products could recognize on the cancer cells to try to allow their killing of selectively tumor cells and not healthy body cells. Now, this is sort of a cartoon type picture illustrating how, in this case, a cytotoxic T cell, a CD8 T cell, as also discussed by Jérôme, can recognize an antigen on a target cell, a tumor cell, where you have an MHC molecule presenting the antigen. And really, the key question that we wanted to answer is, what is the nature of the antigens that are presented by tumor cells that allow these TIL to distinguish tumor cells from healthy body cells? And together with a number of other investigators in the field, and I should mention Ugur Sahin, I should also mention Bob Schreiber and Steve Rosenberg, the hypothesis arose that potentially the DNA damage that accumulates in human cancers can also be a starting point for the immune system to recognize cancer cells as foreign, which in a way is a very attractive thought, because it would imply that the DNA mutation that on one hand cause the disease are also a route to a potential therapy. And we formulated two sort of hypotheses based on this idea. So indeed, if the DNA damage that leads to tumor outgrowth would create the targets for T cells, mutations leading to neoantigens, as they're now called, you would expect, first of all, that in tumor types that are responsive to immunotherapy, the immune system would often show an ability to recognize the mutant antigens in the tumor of that patient. Secondly, if recognition of neoantigens is an important ingredient to cancer immunotherapy, you would also expect that the extent of DNA damage would sort of scale with the foreignness of a tumor, with the tumor being more recognizable to the immune system as DNA mutations accumulate. So we've then set out to start and test these two hypotheses, complicated by the fact that if you look at the mutational profile in individual tumors, the vast majority of mutations is patient-specific. So what we needed to develop is technology to measure immune responses against the potential set of patient-specific neoantigens that would occur potentially in an individual tumor. And what we did, in part with Hypova, but also in part internally with other investigators, is develop technology that allows the high throughput monitoring of immune responses. And this is one of the technologies where we developed technology to load MHC molecules with peptide antigens of interest, thereby creating the tools to then stain T cells and then see by flow cytometry whether there's reactivity of any of these predicted neoantigens. I will not go into further detail about these technologies, but let me just show you what we do with it. We then use this approach for an individual patient. We sequence the tumor, we determine which mutations are present in the tumor, we determine which of these mutations are present in expressed genes, and then we predict epitope for each mutation combined with the HLA allele that is carried by the patient. And then we use our immune monitoring toolbox to test whether there's T-cell reactivity against any of the hundreds or thousands predicted neoantigens that could occur in a patient. Let me give you one very clear example, coming back to the patients with whom I introduced this TIL therapy for you. And here you see the regression, the reduction in tumor burden as a function of time in this patient. So what we did is, for this patient, we analyzed both the TIL product, but also peripheral blood samples prior to therapy and post-therapy to look at reactivity of any of these potential neoantigens. So here I'm showing you flow plots where we analyze the infusion product, so the cell product that was used to treat the patient. And here you see mutations for which we identified T cells that could recognize those. And what you see is that in this bag of T cells, we actually see recognition of 5 different mutant antigens. And some of these antigens are only recognized by a tiny fraction of T cells, 0.1% of T cells in this case, but also in this case, a real outlier, almost 1/3 of the cells sitting in the bag recognize this single mutation. Now, we can also look whether the therapy alters the capacity of the patient to recognize these neoantigens by monitoring peripheral blood over time. Let's just focus on this very profound response that we saw in the TIL product. If we look in peripheral blood pre-therapy, we see a tiny bit of a response, 0.02% of CD8 T cells recognize this mutant antigen. So there's clearly pre-existing reactivity. But now the moment you treat a patient with this TIL product, you see a massive boosting of reactivity against this neoantigen, a roughly 500-fold increase in neoantigen-specific tissue reactivity induced by TIL therapy. Before going to this, let me just add, next to showing this for CD8 T cells, we've in subsequent work also been able to show that for CD4 T cell responses, that in the majority of patients with melanoma, there's reactivity against neoantigens, both cytotoxic and helper T cell reactivity. Coming to the second prediction, as I said, if neoantigens would be important to tumor control, you would expect that the amount of DNA damage would scale with response to immunotherapy. We initially tested this in collaboration with Naya Rizvi in a cohort of patients that received one of the immune checkpoint blocking antibodies, an anti-PD-1 antibody. And here we simply divide the patients into 2 groups, patients without durable clinical benefit and patients with durable clinical benefit. And here we look at the mutational burden in those tumors. And here we also divide the patients into 2 groups, either with a high mutational burden or low mutational burden. And you can see that the patient group with a higher mutational burden has a significantly higher progression-free survival. Furthermore, in more recent work by Ingebrigtsen Svane and colleagues in Denmark, they actually analyzed a cohort of patients treated with TIL products to test whether also upon TIL therapy there's a relationship between foreignness of the tumor as determined by mutational burden and duration of response. And what you can see here, for instance, looking at mutational load and overall survival, that the patients with the high mutational burden have the best overall survival. So, I think this work and work of colleagues, as I also mentioned, really has highlighted the role of neoantigens as one important group of antigens that explains the activity not only of TIL therapy, but also of immune checkpoint blockade. But while doing this work and while analyzing these TIL products, a separate question arose is, what should be the clinical position of TIL therapy? Is it really only a niche for academic investigators to understand immune function, or is there a broader role as potentially a standard of care? So sometimes you start projects where you don't quite realize the consequences, but in the end you're happy that you invested in it, and I think this was really an example of that. because John Haanen decided to start a phase 3 randomized trial of TIL therapy against a standard of care in melanoma patients. This trial took us 8 years, and we only got the final data some 2 months ago. And what we did is we had a cohort of 168 patients randomized to either receive ipilimumab as one of the anti-checkpoint antibodies or TIL treatment. And these are all patients that progressed upon prior treatment for their melanoma. And most of these patients had actually failed prior anti-PD-1 treatment. And then the key question is obviously, is there a difference in relapse-free survival between those two treatment arms? Just an example to again highlight that also in this randomized phase 3 trial that we did together with Ingrid Svane in Denmark, also we see again sometimes very profound responses with ongoing CRs for many years. But most importantly, and very gratifying, we were really over the moon when we saw this, when we look at progression-free survival in the intent to treat population, so all patients included in the study, what we see is that TIL significantly outperforms ipilimumab in this patient group. So clearly, TIL therapy has a significant potential role in the treatment of patients with melanoma. So, do we feel that TIL is as good as it can be? No, we do not, because in parallel, we've used our cohort of TIL patients to analyze those T-cell responses against neoantigens and other antigens and try to understand whether there's room for improvement. And I think there's actually lots of room for improvement. And let me highlight this by coming back to the 3 components of the TIL. So the TIL themselves, the chemotherapy, and the high-dose IL-2. One area of improvement, I think, lies around the cyclophosphamide and fludarabine treatment and also the high-dose IL-2, which are both have significant toxicity. And one approach that we are taking, but also colleagues are taking, is to develop synthetic biology approaches that allow you to achieve the selective expansion or boosting of the infused T-cell pool. So you don't have to remove the endogenous pool anymore. You don't have to treat the patient with high-dose IL-2 that also has significant side effects, but you selectively allow the expansion of the cells that you care about. The more fundamental change that we foresee is actually related to the TIL, where we say, perhaps in the end, TIL is the paradigm to start with, but we don't want to use TIL in a number of years from now. And there's a few reasons for that. One concern, if we look in individual patients, the frequency of T cells that recognize neoantigens is highly variable. I showed you this example where roughly 30% of T cells recognized one of those neoantigens, but actually in many other TIL products, it's only a tiny fraction of the T cells that recognizes mutational antigens that we can identify. And if you could give all patients products with such high frequencies, that would seem beneficial. A second concern, if you look at the composition of those TIL, what you see is that T cells have different differentiation states, with some cells being highly active, highly functional, but other cells being highly dysfunctional, having high expression of inhibitory receptors. And what work from a number of groups has shown over the past years is that actually the T cells that you care most about, those that are seeing antigen, are enriched for the dysfunctional states, which is logical because we know that TCR triggering is a driver of T cell dysfunction. So how could you, in theory, try to get around those types of concerns? And that is by saying, maybe we shouldn't really work with the TIL, the T cells themselves, but only with the TCRs that we care about. The TCRs is the functional element that allows the recognition. If we develop technology to rapidly identify those TCRs in a tumor that have tumor reactivity, we could use those TCRs to transplant them into fresh cells and thereby give a product with a higher frequency of reactive cells, but also more fit T cells. And I think that's something that many people will try to achieve over the coming years. Now, let me then switch more quickly to the second part that I would like to share with you, and that's the work we did with Christian, where we've tried to increase the clinical activity of immune checkpoint blockade. Immune checkpoint blockade, as also highlighted by Jérôme, has transformed late-stage cancer treatment. So just to give you, again, a bit of an overview, what you do with those antibodies is you block inhibitory receptors on T cells, thereby allowing signaling through the T cell receptor and thereby T cell activation and killing of target cells. a major question has been whether you could move immune checkpoint blockade to an earlier disease stage. And there's a number of very compelling reasons to do this. One is the fact that tumors may escape from immune pressure later on. Genetic heterogeneity will increase, so there's more room for dominant selection the moment you have an immune response. And also immune function of patients generally goes down as the disease progresses. Now, if you think about applying immune checkpoint blockade at an earlier disease stage, the most logical thing, at least initially it seems, would to apply this as an adjuvant regimen post-surgery, where you first, the patient receives standard of care surgery, and then you treat the patient with either an anti-PD-1 or an anti-PD-1 plus anti-CTLA-4 antibody. However, Christian and I discussed a number of years ago whether actually you could also try and use immune checkpoint blockade in the neoadjuvant setting. So in this case, what you do is you postpone the surgery and you first treat the patient with neoadjuvant immunotherapy. Now, there's a bunch of concerns. First concern is that you're delaying a potentially curative standard of care surgery. And the second concern is that neoadjuvant immune checkpoint blockade associated toxicities could interfere with the standard of care surgery. However, we also felt there was a very compelling reason to move immune checkpoint blockade prior to surgery, because we thought that the immune boosting capacity would be superior. And from an immunological perspective, I think this is highly obvious. What you do is, with these antibodies, you block the recruitment of phosphatase activity to a TCR, right? So thereby allowing continued kinase signaling through the TCR. But obviously, this is only relevant the moment there is an activating signal present. So if you've already removed the bulk of the tumor load, you've actually removed much of the antigen that actually your anti-PD-1 would be a substrate to work on. So we argued having more antigen on board at the time of ICB should be beneficial, and that would be a reason to develop a neoadjuvant immune checkpoint blockade. So we set up a study to test this, and since we didn't feel we would have the capacity to follow this by looking at relapse-free survival, what we set up is a study to look at immunological readouts, testing whether either neoadjuvant or adjuvant immune checkpoint blockade would differ in the capacity to boost immune recognition of the melanoma. This is the key immunological observation, and I'm not going to go into detail in view of time, but let me just say that these data show that neoadjuvant immune checkpoint blockade leads to superior immune activation, so you are better able to activate tumor-resistant T-cell clones the moment you apply your immune checkpoint blockade prior to surgery. But the second, also very striking observation was that in this small cohort of patients, these were 10 patients in the initial study, 7 out of 10 patients, in just the 6 weeks between the start of the immune checkpoint blockade and the surgery, there was a complete or near complete pathological response of their tumors. So based both on this immunological readout and on this readout by pathology, I think there was a lot of enthusiasm in the field to further test neoadjuvant immune checkpoint blockade. And in work that Christian did with the International Neoadjuvant Melanoma Consortium, it was shown that this high pathological response rate upon neoadjuvant ICB is confirmed in independent studies. Let me just focus on this combination of CTLA-4 blockade and PD-1 blockade, where again, roughly 70% of the patients shows an objective pathological response. Now you could argue, well, this pathological response is very nice, but you're looking at the pathological response in the tumor material that you're resecting anyway, so why would that be beneficial? We thought this would be beneficial because we felt that would be indicative of a stronger systemic immunity and therefore also a lower likelihood of relapse. And that was actually very nicely shown in this study, in which you now look at recurrence-free survival of patients that either had a non-pathological response or a partial or complete pathological response because of neoadjuvant immune checkpoint blockade. And what you see is, if the tumor that you resect shows an objective pathological response, the likelihood of recurrence of that patient is close to zero. It's around 5% maybe. Finally, and I think a really beautiful study done by my close colleague, Tony Ribas, to formally test whether moving immune checkpoint blockade prior to surgery, what the SWOG in the US did is design a study looking at primary endpoint event-free survival in which patients get exactly the same treatment, but the only thing you do is you move the surgery by 3 weeks. Either it's surgery and then 18 weeks of anti-PD-1, or you move the surgery a little bit back and you start with neoadjuvant immune checkpoint blockade, then after surgery, and then continue with your anti-PD-1. And this is really the most clean way I can imagine to see whether neoadjuvant immune checkpoint blockade adds to recurrence-free survival. And these data were presented at ESMO just a few weeks ago, and I think the outcome of the study is really striking. Immune checkpoint blockade prior to standard of care surgery improves event-free survival, not by a little bit, but actually by a lot. Separation between those two curves is very significant. As I said, treatment is identical. The only thing you're doing is putting the surgery a little bit later, inspired by the idea that blockade of PD-1 signaling makes most sense when antigen is abundant. So what I've tried to do is talk about our work, things we found in translation, as I would call it. I think one of the key highlights of the field has been over the past years that we now understand that our T-cell-based immune system can recognize cancer cells based on the neoantigens they express. I think this explains the preferential activity of immune checkpoint blockade and TIL therapy in tumors with a higher mutational burden. And the field is now really developing many efforts to selectively boost neoantigen-specific T-cell reactivity, and Ugur may talk about that later today. We've also shown that TIL therapy shows substantial clinical activity in patients with late-stage melanoma, and as I argued, a number of novel engineered T-cell therapies can be foreseen in which we use the knowledge that we've obtained on those TIL products to design generation 2 and generation 3 versions. And finally, consistent with immunological principles, the immune-boosting activity of immune checkpoint blockade is enhanced when initiated prior to standard of care surgery. I showed you data with melanoma. A number of clinicians at NKI has shown similar data in head and neck cancer, bladder cancer, colorectal cancer, and I think the further development of neoadjuvant immune checkpoint blockade is likely to have very significant clinical impact. With that, I'd like to close. I would like to stress that this has been an effort of many, many people, many more people than are here on the slide. I would again like to acknowledge the very important contributions of both John and his team and Christian and his team. I'd like to thank the funders of our work, and I'd like to thank you for your attention.
Thank you. Questions?
Thank you, very nice presentation. I just have a quick question. Are you also looking, in addition to the new antigens, which are point mutation, into other class of new antigens like splice variant, frame shift mutation?
So, yeah, no, it's an important question. And I think the field is a little bit divided how we should define neoantigens. Frame shifts certainly belong to that class, right? Because they are encoding novel sequences that's not there in the germline. Splice mutations is a little bit more difficult because there it's not always clear whether absence of that splice variant in other tissues is complete. So I would say that we should think of neoantigens as those sequences for which we have credible evidence that they can't be present in other tissues. And certainly SNVs belong to this, but also frame shifts. And large translocations also.
Thank you. This question here.
As the role of immune system in treating cancer becomes increasingly important, that's obvious. Do you think it might be conceivable that we could preventively stimulate our immune system to protect ourselves against?
Yeah, that's an interesting question. Looking at this question from a neoantigen perspective, I'm not completely sure, because we do not know in advance which mutations will be present in an individual tumor. There may be a bit of an exception there, for instance, in patients with Lynch syndrome, where you can, to some extent, predict which frame shifts are more likely to occur. So there I could see some room. But for other tumors where the mutational profile differs for each individual tumor, I think it's harder to envision a preventive strategy.
If no more questions, thank you for a nice talk. So our last speaker in this session is Patrick Cramer, who's the recipient of the 2021 Louis-Jeantet Prize for Medicine for providing an understanding of the structural and biochemical aspects of gene transcription in eukaryotic cells. He's currently director of the Max Planck Institute for Biophysical Chemistry in Göttingen, and his topic is mechanism of gene transcription and its regulation.
Thank you very much. It's wonderful to be here and to participate in such an exciting symposium. Thank you all for coming. It's also great to stand here and see a full lecture theater. I hope I can entertain you today by bringing you up to date with respect to our latest insights into the mechanism of gene transcription as well as the regulation of mRNA synthesis by my favorite protein, RNA polymerase II. Let me start by thanking the many people who have been in the laboratory over the last, more than 2 decades, and especially those who are currently in the lab who produced a lot of unpublished data that I will show, but also the many people who went through the lab, and actually I'm extremely happy that 20 of them went on for PI positions. They have their own laboratories, and so the kind of science you will hear is continued by many people in different parts of the world, in America, in Asia, but also, of course, in Europe. 10 years ago, we published the first movie of RNA polymerase II transcription, and that was based at the time purely on X-ray crystallography and biochemistry. And when you look at the nucleotide addition cycle, you can actually see the, the nucleoside triphosphate here in orange entering the active site, and then the active center closes, a phosphodiester bond is formed to extend the mRNA that you see here in red by 1 nucleotide. And then in a mechanism called translocation, the next template base is brought into the active center and the whole cycle can repeat itself. So this is the basic mechanism of transcription. But of course, the big challenge has been, and also for the future will be, is to understand the mechanism of regulation of transcription. And why is this so important? Well, first of all, it's mainly the regulation of Pol2 transcription that underlies embryonic development and the differentiation of cells, but of course also the dysregulation that underlies the formation of tumor cells, of cancers, is very interesting to study, because if you could target that, you would have new possibilities to treat cancer. And actually some of the enzymes that are currently targeted are regulators of Pol2 transcription. Now, how can you even dare to study such a progress as Pol2 regulation? There's 1,800 transcription factors encoded in the human genome. Just a few of those you saw by staining of this embryo that I just showed you. How can you dare to study such complex regulation? Well, the approach we took is to stay around the polymerase enzyme to really take care of the structure and function of the many intermediates of transcription, because the rationale was that these transitions between the different transcription intermediates would be actually the targets for these many transcription factors, and they would regulate the process by lowering or increasing the activation barrier for these transitions. So the first thing you have to do when you think about the problem as a chemical problem is to define the structure of the intermediates and then to understand the transitions. So we tried to serve the community by looking at these many intermediates at the beginning of transcription, which are known to be on the pathway for regulation. So you start by opening the chromatin, and only then, when you have an open promoter region, a pre-initiation complex or PIC can form. So the polymerase is recruited together with general factors. Now the DNA can open, mRNA synthesis starts, but the polymerase doesn't get very far. It normally pauses when it reaches about 50 nucleotides, when the mRNA length is about 50 nucleotides. And then there needs to be an exchange of factors and phosphorylation events, and then the polymerase is released into the gene, it's activated, and then it can pass through nucleosomes, through chromatin very rapidly. This is still astonishing, you know, it passes through 10 or 15 nucleosomes a minute, and it can synthesize 3,000, 4,000 nucleotides of RNA. Now we try to serve the community by filling in these intermediate structures over the last 2 decades or so. So we have now a few of the different intermediates, and we can compare them and try to understand the transitions. But most recently, we also filled in some gaps in between that further our understanding. I will not have time to discuss all of that, just to show you how complex of a reaction the early transcription process is. And I will concentrate on a few very interesting highlights and on a few new unpublished results. So we will start at the very top from chromatin opening. I'll give you some insights here. Then we go to the PIC formation. And then we go to what we call the early elongation control, when the polymerase pauses and is released. And then in the end, I will tell you a little bit about nucleosome passage and actually show you a very recent first movie of how we can envision a polymerase go or travel through a nucleosome. So not all of these transcription factors have to wait until chromatin is opened before they can bind DNA. Some of them, the so-called pioneer factors, can bind to nucleosomes. And what we saw in this first structure of a pioneer factor bound to a nucleosome, that these factors can use binding energy to distort nucleosomal DNA and also to unwrap some of the DNA from the histone octamer, and that generates more accessible DNA. But that's not enough. These factors also have to recruit large enzyme complexes, so-called chromatin remodelers, to open the chromatin completely. And they do so by using intrinsically disordered regions, these tail-like regions, which recruit then large complexes such as these switch-SNF remodelers, which is a famous family of remodelers, multi-protein remodelers. And in this animation, we give you an idea of how we envision the process. So basically, there's an intrinsically nucleosome-depleted region in the genome, but that is a very small region. You have flanking nucleosomes called the +1 and -1 nucleosomes. And these remodelers can bind on either side, and they can shift those nucleosomes outwards. So as a matter of fact, you can increase the nucleosome-depleted region, so it becomes large enough for the large pre-initiation complex to assemble on promoter DNA. And this was a real tour de force. We have been working on that to get this pre-initiation complex structure for 20 years. Going step by step, making more and more proteins, first using crystallography, then cryo-EM, and also cross-linking and mass spec. And then eventually now we just recently published the structure of the yeast and the human pre-initiation complex. These complexes have around 50 polypeptides. And I should mention also that the lab of Eva Nogales has been active in this and has done wonderful work on the human pre-initiation complex, and more recently also the labs of He and Shu. So we have now both types of complexes, and it was important to go for both yeast and human despite the conservation, because it turns out that some aspects of the mechanism we could only unravel for technical reasons, either in the yeast system or in the human system. But by now we not only know how the promoter is recognized, we also know how the DNA is opened, and we know how the RNA chain synthesis occurs. Now, it was important for us to take the next step, looking into regulation, and also use functional genomics. So we had previously only used integrated structural biology and biochemistry to study mechanism in a bottom-up approach. But now, as we were looking into regulation in greater detail, it was very important to also do functional genomics in cells, in vivo. And computational biology is actually the glue between the two. So you can either generate a hypothesis using structural biology and biochemistry, and then you test it in cells, or you generate a hypothesis in cells from correlation analysis using functional genomics, multi-omics, and then you test that hypothesis in the test tube using structural biology or biochemistry. And this way you can really work forward towards understanding regulation. And so one thing, for example, that you can do, you can ask, where on the genome do I find those intermediates? The intermediates that I've shown you, where are they sitting? Promoter, in the beginning of the gene, further downstream. And this is what is called occupancy profiling, and it gave us very good insights into where the so-called pause complex is sitting. Remember, the polymerase is initiating, but now it's stopping about 50 base pairs downstream of the start site. And then that pause complex is sitting in front of a nucleosome. And this we know from functional genomics. So now we can go back and get a structural model of that situation, because we can put together the pieces of the different structure in the right order and at the right distance. And this is the model you see here with the pre-initiation complex, the pause polymerase in front of a nucleosome. Now, that pause polymerase is a very important intermediate. It only exists in metazoan cells. You don't find it in archaea or in yeast cells. And the reason is it's an additional regulatory level for regulating transcription, because that pause polymerase can now be terminated, or it can be converted into an active elongation complex. When the integrator binds, it will actually be terminated. So the integrator complex is another very large assembly, 16 subunits. We could make it by co-expression and then bind it to the pause polymerase, to its target. And from this large complex with like 34, 35 subunits, you can get insights into how the pause polymerase is terminated. So basically, transcription starts, but it doesn't get very far. Polymerase is terminated by this regulatory integrator. And just to show you one interesting aspect, there's a subunit in this integrator complex, which is an endonuclease. And when the target, the pause polymerase, is bound, this endonuclease opens its active site, and now the RNA that exits from the polymerase surface can bind to the endonuclease active site, and it can get cleaved here by the integrator. And that cleavage takes place exactly 20 nucleotides, or more or less exactly around 20 nucleotides from the active site of the polymerase. And that is again in agreement with data from Karen Edelman, and they use also functional genomics. So it's a mechanism that clearly occurs in cells. Now, this cleavage will remove the 5' cap structure, which protects the pre-messenger RNA. So that complex becomes vulnerable and then eventually gets terminated. Now, but of course, when there's positive signals, you want the pause polymerase to escape from this promoter proximal site into the gene and actively transcribe the gene. And this happens when a kinase complex binds, which is called PTEFB. And that kinase complex is doing a lot of types of phosphorylations on different factors, and that leads to a destabilization of the pause complex and a stabilization of this highly active elongation complex, EC star, which now carries some of the factors that you need to carry on transcription in a very fast and processive manner, and also some of the factors you need to go through chromatin very rapidly. Now, when you look at this whole situation, it becomes more and more complex, and so we developed multi-omics approaches. This is basically different types of functional genomics methods, and we combined that with kinetic modeling, mathematical modeling, and this allows you to actually extract kinetic parameters from the transcriptome and the genome in living cells, so you can actually put some kinetic parameters on this reaction scheme. So now you see we go from understanding the different intermediates to an understanding of the transitions. And now if you perturb the system, and this is what I want to show you, you can also ask, you know, what are the regulatory processes in cells? And so what we did is quite simple. We inhibited this kinase, PTEF-B, and that can be done with the so-called Shortcut system, where only a single kinase is inhibited very selectively with a drug, with a small molecule that you give to the cell culture. And then we can do this multi-omics kinetic analysis before and after we give the drug, right? And we inhibit the kinase. And then we can see what this kind of regulation is all about, what is actually happening in cells on the kinetic level. And that's the one movie I want to show you. And what that movie shows is, first of all, something that you would expect, because if you inhibit that positive kinase, the paused complex is stabilized. So on the y-axis here, you see the duration of polymerase pausing. So in minutes, actually, the polymerase is pausing longer because now this kinase is inhibited that is needed to resolve the pause and to activate the polymerase. But quite unexpectedly, what we saw is that the frequency, the productive frequency of initiation is downregulated quite dramatically. And this is a very important finding because it can actually explain how you can regulate transcription at all on the elongation level. Because this was mysterious, you know. People knew these are important intermediates for regulation, but it was totally unclear why this is so. And the reason is, when you regulate the speed of the polymerase, the pause duration, the elongation time, it's not obvious at all how that should regulate the number of messenger RNA molecules you make per time. Because the pausing takes a few minutes, and if you look after half a day, how many mRNA molecules do I have, it will be the same number no matter whether the pausing is 5 minutes or 10 minutes. So to regulate the number of mRNA molecules, or in other words, to switch the gene on or off, you have to regulate the initiation frequency. And see, the important take-home message here is that this paused complex actually is inhibitory to new initiation. So this initiation complex can form every few seconds, but since there's a pause complex in front of it that resides there for a couple of minutes, this puts a limit to the initiation frequency, and that beautifully explained how you can have additional levels of regulation in metazoan cells that are important for differentiation and also cellular responses. Now I think we understood better how we get to this active transcription complex, which now carries the transcription factors you need to go through chromatin. And I want to show you a few things about what we understood recently about this intricate process of a polymerase moving through a nucleosome. I cannot report on everything, but to show you the first movie and to highlight a few aspects of the process. But all these factors are actually involved to some extent and several more. But this is, you know, one of the first movies where this can be visualized. It's a little bit of science fiction still because we interpolate, but it's based on about a dozen or so structures that we resolved in different states of the complex. So the polymerase moves into the nucleosome. It's a strong motor. It can unravel the DNA from the histone octamer. And at some stage, the H2A, H2B dimer is lost from the histone octamer because DNA is unraveled there. And so you have left a hexasome. But this hexasome, of course, tries to hold on to the DNA. And there's a competition between polymerase and this hexasome. And the hexasome can also force the polymerase to move backwards. So now everything runs backwards because the hexasome wants to regain DNA contacts. And the RNA now emerges in a reverse direction through the polymerase. We call this backtracking. Now the polymerase is arrested, but this factor TF2S can cleave the backtracked RNA and restart the polymerase. Now the polymerase has a second chance to go through the nucleosome. And this process actually happens repetitively until you finally make sure that the polymerase can move through the nucleosome. Now, what happens to those hexasomes that you form, right? You need to re-establish proper chromatin. This is something that we really don't understand, but I want to share these unpublished data. We just found that one of the remodelers, CHD4, can actually form complexes of hexasomes and nucleosomes, and another one, CHD1, can resolve those. So this is a possible pathway for how these intermediates that the polymerase is generating, how they could be rescued and how chromatin could be reestablished. There are certainly more mechanisms, but at least we have a first suggestion how this may occur. And I show you the movie once more just so that you appreciate the beauty of these remodelers, because there's something conceptually very new here. So we first look at CHD4, the one remodeler that is actually forming these hexasome-nucleosome intermediates. So CHD4 binds to the nucleosome part of this particle. So here's the nucleosome, and down here's the hexasome. And it binds to the nucleosome and then withdraws DNA from the linker. So in other words, it's pulling the hexasome into the, or near the nucleosome. There will be some stacking. And what's so interesting is that CHD1, which is a closely related remodeler, is doing the opposite. It doesn't bind to the nucleosome, as you see here. It actually binds to this hexasome part. And when it binds to the hexasome, it actually does the opposite of what CHD4 is doing. It will actually pump the DNA into the linker region. So in other words, it can remove the hexasome from the nucleosome. And that means that two highly related remodelers function differently. Actually, they have the opposite function. And the reason is the higher order structure that we look at here. You know, so far when people studied remodelers, they looked at mononucleosomes. But these machines evolved in higher order chromatin. And now when you take larger substrates, you can see these differences. We actually also know why the remodeler binds on one side or the other. It's very exciting. It can really recognize the neighboring particle in chromatin. Yeah, this is what I wanted to show you today. And I want to leave you with a very simple take-home message, because you've seen how complex early transcription is and how manifold the types of regulation are. But actually it boils down to a single take-home message, and that is shown here on the left. Whatever you do, you know, whether it's regulation on the chromatin opening, whether it's acetylation of histones, or whether it's the paused polymerase that can be terminated or converted into an active complex, all these regulatory steps, no matter whether they are downstream or upstream, they will converge on the initiation process. It's kind of a trivial take-home message, but it's very important not to get confused. And when you regulate the initiation process, what you do is you regulate how many mRNA molecules do I make per time. And this is, you know, when we talk about a gene is switched on or off, this is really what you need to do. You need to regulate the number of mRNA molecules per time. But you see how many different possibilities you have to do that. And why is that so? I think it's simply because when Metazoa evolved and there was this need for differentiation, and suddenly instead of 200 transcription factors, you almost have 2,000. It was not possible to just evolve that type of regulation on a core promoter. It's just not enough DNA sequence. But if you also, you know, can evolve the DNA in neighboring and flanking regions, you influence the nucleosome positioning, you influence, you know, whether nucleosomes can be moved and in which direction, and you influence whether the polymerase can be paused downstream. You have all these possibilities of evolving a gene and the regulatory options. And this is, I think, where it comes from. But the actual regulation at the heart of the process is simple. It's the initiation that is regulated. And just one more minute before I stop to give you a glimpse of the future. You know, this is a nice artistic view of what I was trying to tell you, namely that chromatin and the transcription machinery co-evolved. It's not just about packaging genes. It's about making regulation possible when it becomes very, very complicated and when you have to have very different types of gene regulation. And this co-evolution of chromatin and the transcription machinery will only be fully understood when we actually get a structure of an active gene, a structure of a repressed gene, a spliced gene, a non-spliced gene, and all of these things, a non-coding gene. So how can we ever get those structures? Now, the approach that we are taking is the following. We want to get a picture like that, but a real picture, not an artistic drawing, an experimental, evidence-based picture. So we isolate now very carefully chromosomes, and we look at parts of chromosomes by cryo-electron tomography. And our hope is that, and these are the pictures we got after a lot of biochemistry, so the individual grains you see are nucleosomes, so we begin to see details here. And then the hope is that we can use the many, many structures that we solved of large assemblies over the years and fit them in and get some kind of hybrid structure where we really see parts of genes or even entire transcribed loci. And finally, maybe for a teaser for this afternoon, where we will hear a lot about mRNA vaccines and coronavirus and so forth. When you know about polymerases, then of course it's a lot of fun to look at viral polymerases also. And when the pandemic hit, we solved the structure of the corona polymerase, which replicates the RNA genome of the coronavirus. And that was important, I think, because it allowed us to visualize how the first drugs against COVID-19, remdesivir, molnupiravir, that actually interfere with the polymerase of the virus, how these drugs actually work. We could make movies of those drugs inhibiting or influencing the polymerase of the virus. And now we are, because both drugs are not ideal, they have different issues, we are screening large libraries together with Herbert Waldman, hoping to get compounds that we can develop into new antivirals. And we have a few dozen of interesting hits that have totally different chemical structures. This is what I wanted to tell you. Thank you so much for your attention. Thank you so much.
So maybe I'll start the questions myself. I think there's more and more interest in DNA double-stranded breaks being a regulator of transcription. How might that fit in your model?
Yeah, this is a wonderful point. So we haven't studied that. That's something for the future. It's very complex, as you know, because now the DNA break machinery and damage recognition machinery, all these proteins are recruited. But there are several publications that indicate there's a role for RNA synthesis from such lesions in the repair process, but the mechanisms are not understood. We have recently published, how transcription is coupled to DNA repair of UV lesions, cisplatinum lesions, and so forth. But that mechanism actually, we think, is very different from the one at double-strand break. So there's actually multiple transcription-coupled DNA repair pathways.
Thank you. Other questions?
Michael.
Yeah, that was a beautiful talk, by the way. You described the step where the polymerase has difficulty clearing the first hexosome and then goes backwards and clips the RNA and then tries again and then succeeds. I understood that happens in the first nucleosome, not the second or third, or et cetera. So what is different? Is there a more robust modeler that acts downstream, or what's happening there?
Yeah, that's another very interesting question. Thanks, Michael. So basically, the question is, in higher order chromatin, is that happening at each nucleosome, or is it different when you transcribe multiple nucleosomes? I'm sure we don't know, but I'm sure there's something very intricate and very fascinating about the mechanism that actually enables the polymerase to go so fast through so many nucleosomes, generally without the loss of the histones, because as you know, if you would really drop the histones, you would lose the information that is stored in the modification of the histone tail. So chaperones certainly play a role. I didn't have time. We have the structure with FACT, which is actually preserving the histones at the site of transcription and helping the polymerase to shuffle them to the wake and reintegrating them. So these chaperones play a role, but there may be something very important about the stacking of nucleosomes, because when you actually solve structures of such nucleosome arrays with the distances that occur in actively transcribed genes, you see stacking of nucleosomes, but it's nucleosome 1, 3, 5, and so forth, and then there's an intermediate nucleosome. And when you then make a model, we don't have structures yet, but when you make a model, then some of the large complexes that bind the polymerase can actually reach over to the intermediate nucleosome. And I wonder, whether there's something along the lines you envision that once you make it through the first, you deal more easily with the second, third. But we really don't know how that works. It becomes, too difficult for the human brain to understand that in 3D. Even we have, of course, our 3D glasses that help us before we make such movies, but it becomes really difficult in 3D when you look at higher order chromatin.
Thank you. I think there was a question here.
Hello. So I have a question regarding, I have a question whose answer is probably hidden in your fascinating work in the structure of genes themselves. But I was wondering how the pre-initiation complex, as well as the polymerase, deal with the bidirectional promoters as compared to the unidirectional ones.
Yeah, that's a great question. And we know from functional genomics, from people like Lars Steinmetz and others, that when you look at the nucleosome-depleted region, there's a pre-initiation complex in the sense direction and one in the anti-sense, in the upstream direction. And when you actually make a model and you take the shortest known nucleosome-depleted regions, you can just fit two pre-initiation complexes back to back. So in principle, they could fire at the same time. Whether they do, we don't know. We need to wait for high-resolution light microscopy in living cells. But we know it's two pre-initiation complexes. And we also know that, the one that goes in the wrong direction, the antisense one, it will never mature to this kind of, a highly processive complex. And beforehand, it will lose factors, it will get destabilized, and then there's a specific pathway to terminate those complexes.
Yes.
You mentioned in the beginning the pioneer factors. So are the genes that are regulated by pioneer factors, are these different steps that you described different in genes that are transcribed or initiated by pioneer factors?
Yeah, that's another really interesting point. I didn't have time. So what we've done a trans differentiation. We moved B cells to macrophages by expressing a transcription factor. It's a system from Thomas Graf. And then you can follow that over 3-4 days until you get the new cell type. And when you then do multi-omics, what you see is that it takes a day or so for pioneer factors to come, for remodelers to come, for, the promoters for the new cell type that they are finally open. Takes a full day. And then once they're open, pre-initiation complex is immediately there and it starts to transcribe. You cannot even distinguish that. So it's a very, it's a very slow type of regulation on the chromatin opening level. And the kind of regulation that I described is very fast. And that's why I think, the chromatin changes are more for establishing cell types, keeping things also stable longer term. And this type of very rapid regulation is more for the immune response, stress genes, rapid differentiation events and things like that. And so it's actually this kinetic dimension that we need to explore much better to fully understand, because these pictures are normally static and, it really matters whether a complex lives for seconds, minutes, or even hours.
Thank you. So thank you to all three speakers for very impressive talks, and to the audience.
Welcome back to our symposium, to our third and final session. This session is devoted to the laureates of 2022. And the first speaker is Cal Robinson, who is the recipient of the 2022 Louis-Jeantet Prize for Medicine. And she's recognized for establishing mass spectrometry as a rigorous method to analyze the composition of protein complexes and their interactions with small molecules. So Cal Robinson graduated from the Royal Society of Chemistry in 1979 and subsequently completed her PhD studies at the University of Cambridge. She then did what is a very rare, and I would say impressive, phase of her career, and that is she took an 8-year career break to raise her children, after which she became the first female professor of chemistry at the University of Cambridge. Very impressive. Since 2009, she has held the Dr. Lees Professor Chair of Chemistry at the University of Oxford, and is also Oxford's first female professor of chemistry. Since 2021, she has been also director of the Kavli Institute for Nanoscience Discovery. Carol.
Thank you very much for the introduction, Michael. I think I have a very hard slot just after lunch and before the amazing vaccine story. And I have to impress you that mass spectrometry is really something you want to listen to. It's going to be a very different type of mass spectrometer to what you've heard of before, so I hope I can keep your attention. I'm going to start at the beginning of my career when we were interested in how protein folding could be represented in a mass spectrometer, and then move to our very recent work, which is about signaling across native membranes. So, very old slide, very low tech back in those days. We were interested in how molecular chaperones, in this case Graziella, that you'll have heard of, how it could sequester a small unfolded protein and how it could monitor its folding. And you have to remember that at this time in the early 1990s, the mass spectrometry community were somewhat interested in resolution and mass accuracy. And by doing these type of experiments, you destroy actually both of those parameters. You have very broad peaks, you don't have very accurate masses, and you really can't decide fully the mass of your protein. You get a bandwidth for deuterium that's added during folding. So we were able to determine that the folding was partially folded within this cavity, but that wasn't the interesting thing. The interesting thing was that you could take something that was as large as 800,000 complex and put it into a mass spectrometer. And we always assumed that it fell apart as it was trundling through the mass spectrometer. It was a very much larger thing that had been studied before, but we could never prove it. And we had a lot of sort of backlash of commentary saying that, you can't really expect to monitor folding when you're in a vacuum of a mass spectrometer, when life as we know it goes on in the cell or in water is better, but in the vacuum is the worst place to be. And there were a lot of predictions that a Graziella tetradecamer, 14 subunits, would actually invert because the forces that keep it folded and in its right conformation have all now gone. All the water's gone, so how could it be right? But the 14 subunits, when we got the right design of mass spectrometer, we could persuade them to stay intact. So clearly, they were interacting in their, I say clearly, I think clearly they were interacting within their two rings and holding together. And they weren't, if they were inverting, they would probably fall apart, and that we did not see. And in fact, over the years, we've managed to make much better spectrometers such that we can now resolve the 14-mer and also a single ring species. But there were still many comments and much skepticism. And so we thought that one way to overcome this would be to introduce an EM grid. This was a crazy experiment at the time. But what if you could collect them as they were flying through the mass spectrometer, take them out, and actually, with your own eyes, see that they had the right topology? And I'm going to come back to this at the end, because it's suddenly taken a new twist. But at that time, this on the left-hand side, you can see the spectra as the beam of ions are going through the mass spectrometer, and then we optionally push through this grid and start to land. First one's great because we did that before it was in the mass spectrometer. The middle one is not so good, and the end one is pretty indistinguishable. So although we could pick out with the eye of faith something that looked about right, it was hardly conclusive. And we also thought about this. You know, this is something that's normally in water, and it needs this sort of hydrophobic thing to get it to stay together. But what about if we changed track and went for a membrane protein? Because as you know, they have very different properties, and the dielectric constant inside a membrane is thought to be very similar to inside the gas phase. So perhaps this is a much better place to be. So we started, this is my Chilean postdoc who was very good at handling membrane proteins and knew nothing about mass spectrometry, which was actually quite helpful because he managed to get this to work. And I'm just showing you the sort of thing we saw. So that's very, very ugly, if you ever saw anything like that. But out of this sort of soap bubble comes these resolved peaks. And this was actually the intact ABC transporter, BTUCD. So although he almost broke the spectrometer in the process, I was actually delighted because it was the first time we'd ever seen anything come out of a detergent micelle intact with lipids associated. And this was in 2008, and again there was another comment, well, for how long and under what conditions and to what extent can this solution structure be retained? And at this time, McLafferty was the most famous mass spectrometrist, and so he didn't really want to go against what he was saying. But I was confident that we were right, and I'll show you towards the end that we've managed to now prove this. So again, we kind of pushed on, not heeding the critics, and thought, well, we'll go for the intact ATPase. That's a hugely complicated thing, and it couldn't be aggregating and coming together with this very unusual 29 subunit stoichiometry. If it was preserved, it must be as it is in the membrane. And Minju was the hero here who worked very hard on this. And what we found was that the 29 subunits did indeed stay intact, but importantly, they also had a ring of lipids that stabilized the inner ring, the rotor, which sits in the membrane. And we went on to show how different types of ATPases actually recruited different lipids into those membrane rotors. And this really got us thinking, maybe we have a really great way of exploring membrane protein lipid interactions. It's a very difficult thing to capture. As you know, EM, magnificent as it is, can't always define the head groups or the chains in some of the lipid density that they see. And these lipids are actually, I believe, very important for controlling the function of many of these complexes. And what we found was that if we could take two homologous transporters and express them even in the same sort of membranes, they would have very different lipid binding properties in the mass spectrometer. So this is a sodium proton antiporter from an E. coli on the left and from a thermophilic species on the right. And on the left-hand side, you'll see, even if you don't like mass spectra, you'll see that this is actually a very complicated one compared to this one on the right, which is very clean. So they're both dimers, so they're both proton antiporters that are dimeric, but one of them requires lots of lipids to sort of staple across the interface and confer its stability. So even in the same membrane environment, they have these very different properties, which are obviously in the sequence of the protein. So we started to think, well, maybe that gives us a sort of sliding scale of lipid dependence. If you have a very stable interface, maybe you don't need these stapling lipids. And if you have a much weaker, more transient membrane interface in a membrane, perhaps you really need to glue them or staple them with a lot of lipids. And so we had this hypothesis, really, that we could plot membrane proteins according to their stability to work out how much their lipid dependence was. And it was actually while looking at this sodium proton antipores, these 7 transhelical things, that I started to think that actually maybe we should start to look at GPCRs. At the time, I was going to a lot of conferences, and people were debating whether or not they were monomers or dimers, whether they signaled as monomers or dimers. And we thought, we have the tools now to go and answer this question and to see if they signal as monomers or dimers, or whether they have a huge lipid dependence. And you'll see that all of the ones that I've plotted here actually have quite weak interfaces, and actually some, in the second one from the left, you can see that there's a little bit of density already modeled there, suggesting that maybe it's lipids that modulate these dimer interfaces. We set out to look at GPCRs with some trepidation, because it's quite a contentious field, and we realized quite quickly it was very difficult to get them into the mass spectrometer. There's one thing about putting in a very rigid rotary ATPase or an ABC transporter. A GPCR is so membrane context dependent that it's actually very hard to keep it folded. So we struggled initially to look at it with its downstream signaling partners, but we found Jason was a bit of a hero here. He spent many nights determining different lipid detergent mixtures that would give it the stability to survive in the gas phase. And this is the A2AR receptor bound to a mini G, which is a sort of, it's a mimic of the G alpha subunit. We've got gamma and beta, and then a nanobody giving additional stability. And although the upper right spectrum isn't the best, as you can see, when we did the tandem mass spectrometry, we were able to see all of the components. And the interesting thing was that the A2AR came out with 2 lipids associated, suggesting that perhaps lipids were involved in this downstream signaling cascade. And I won't go through all the experiments there, but just to note that we were able to show that actually it's PIP2 that comes in the green here and helps to select the G protein of interest, and then sort of clamps that protein up into the bottom of that receptor when it's active and signaling. And it's quite selective. It doesn't bind to other Gs. We showed lots of different experiments, but I don't have time to go into that. But one of the things we always thought about with these experiments is that if you take a membrane protein out of its environment in a detergent bubble, how do you know that the lipids that are coming along are actually the ones that it really needs and interacts with? Or have you somehow perturbed that equilibrium by the very act of putting it in detergent? And of course, this has always been the thing. These look fascinating and amazing, but are they the same when you've dissolved them up in detergent? And many people say, well, you can't actually do anything unless you start by dissolving the bilayer. And I think, what if we didn't have to do that? Wouldn't it be a transformative way of looking at membrane proteins if you didn't first have to dissolve them? And so that set us on our next period of research, which was to just not use detergent. We made many, many detergents and we still use them, but if we didn't have to use them, let's try not to. And so we went directly now from vesicles, either from mitochondria. We've tried mitochondria, we've tried plasma membranes, we've tried many, many different membranes, all the bacterial ones, and try to just pop out the complexes from their native environment. So again, some mass spectrometry developments were needed, and the conditions are actually reasonably harsh at the front end to liberate these from the vesicle, but then very, very soft and gentle to keep all the components together. And I'll show you just 2 examples here of the difference. So complex 1, you'll know, is part of the supercomplex in the membrane, an OXPHOS complex, and you can see in the upper spectrum, in a detergent micelle, the spectrum doesn't have as much resolution. It's very hard to pick out the lipids. If you go directly from detergent, not only do you maintain a huge number of these protein subunits in complex, but you can also pick out what I believe are the structurally important lipids that reside actually within the membrane. So they're no longer the ones that are in the detergent bubble, but actually the ones that are interdigitated between the subunits in complex 1. So I thought this is a very exciting step forward. We would still need a little bit more resolution on those cardiolipins, because currently we're saying it's cardiolipin, and then people will say, well, what's the chain length, what's the unsaturation, etc., etc. So we then started to bring together lipidomics with our native mass spectrometry approaches to really sort of see if we can get a much better and tighter grip on what's happening with the lipids. And I'll just show you one here. This is from the mitochondrial transporter, TSPO. And this was a controversial paper in Science where the density in this structure was not very well accommodated with the lipid that had been proposed. So we thought, well, this would be quite a good test case for us, because we should be able to take this complex, keep the complex intact, and then break it and release the lipid. And I think that's the important thing, because if you do proteomics and you do lipidomics, you don't really know which is the one that's in there. You tend to get hundreds of lipids, and then you have to try and fit them, and you're never really sure which one it is. So by this method, you keep them all together in the gas phase and use the gas phase as your sort of fractionating thing, and separate the protein and the lipid, and then break up the lipid. And we did this, and we saw there were quite a few lipids, but there was one major lipid which we could now get all of its unsaturation, and you can see how much nicer it fits into the density. So we were able to fit this into an EM map and show that actually we can use this method. This is a recombinant protein, but we can use this method to define the lipids that are interacting with the protein. So the next step is to not have a recombinant protein, not have a detergent micelle, but to be in a native membrane. Try to go again from a native membrane and capture signaling. And of course, there's one molecule that behaves so nicely, and it's the one that allows us all to see, which is, of course, rhodopsin. Now, rhodopsin signals, it's sort of made for mass spectrometry in a way, because you can have everything in register, and then you turn on the light, things start to signal. You can't do that very often with GPCRs. It's quite difficult to get a controlled start, because it takes a little bit of a while for the agonist to get in, etc. When you shine light, it's instant and beautiful. So we take rhodopsin, we shine the light. There's an equilibrium between rhodopsin and opsin. Activated rhodopsin then signals through transducin, and DP comes off, GTP goes on, and it interacts with PDE6. And we also get the G-alpha coming across and interacting with PDE6. All of these have changes in mass. So, as I say, made for mass spectrometry in some ways. And we really wanted to see if we could do that, not in a micelle, but across the membrane. And so Sahin is my hero here, because she worked all through the lockdown. Because it's okay to be in the dark room all by yourself, sadly, which is what she did. So we moved a mass spectrometer into the dark room. So we're working under red light. We have eyes that are all being sacrificed in the dark. And there's, I introduce you to Sahin in her mask, the sign of that time. And she's recording there in the dark. So she has rhodopsin primarily. And then as she switches on the light, you'll see that with a trained eye, you'll see that the signaling is taking place and the peaks are changing as a function of time. So this is rhodopsin coming out of its native membrane into the mass spectrometer, and the opsin-rhodopsin ratio changes as we speak. It does take a bit of a trained eye to see that, so don't worry if you missed it. So here we are, she's out of her mask outside, and this is the experiment. Take these disc membranes and form the vesicles. And what's nice about this experiment, as I say, everything is characterized by mass, and we do no separation. So everything the signaling cascade is in the tube going into the mass spec. And these are all the components, the transducin, the rhodopsin, and the PDE6. And what can we learn? For a while, we were sort of anxious because there's 40 years, maybe more, 50 years of rhodopsin research. And we thought, well, if all we do is show we can do it in the mass spec, no one will care. We need to find something new. And what we did find was that if you expose rhodopsin to light, as expected, it forms opsin over time and the two peaks change. But if you suddenly flash the light back on again, it very quickly regenerates. And we could see that rhodopsin suddenly formed again. And this was quite puzzling because we thought, well, it can't be an enzyme reaction. That's way too quick. So it must be, we believed, something to do with it being in the membrane because it's never seen in detergent. And what we found was that the membrane actually holds very tightly onto a lipid that stores this retinol chromophore so that it can go back in when you flash on the light. So that's right on the top left hand. And these are the two different reactions in detergent and in membranes. And if you look at the 3-minute mark, you can see that rhodopsin is still surviving the red peak in after 3 minutes, whereas and going down to opsin, whereas in LMNG both peaks are equal. So you can see that the reaction is slower in the membrane, and you can postulate that that's probably because the membrane offers some support. The lipid environment is making the transitions of the rhodopsin signaling a little slower. So what does this all mean? We can then also look at the interactions with transducin and the G-alpha coming across to PDE6. You can see at the bottom, in the top spectrum, we've got cyclic GMP, and as we add, as the reaction undergoes, we get cyclic GMP hydrolyzed and coming off of PDE6. So again, a nice mass change for us to monitor. What can we do? We can now look at endless drugs that either speed up or slow down retinol signaling. And you'll see that I'm just going to whiz through this part because I need to finish. But we can do high throughput screening within a native membrane with all of these different compounds and complexes. Yeah, so red lit mass spec, turn the light on, spray across, and all of the components are captured, signaling across the membrane. And just to finish, you remember I said I had a lot of comments and negative press, as they say, when I started with this question, well, you know, how long can it really stay? Not really sure I believe it. And of course, recently, EM has taken off, and in the Kavli, I'm very fortunate we have an EM that I have easy access to. So revisiting this experiment of can we land something in a mass spectrometer, these are just two regular, this is unpublished, but these are just two regular membrane protein complexes, aquaporin Z and the ammonia channel. And these are coming along with a series of lipids and detergents and being landed directly in the mass spectrometer. So we know that there's still detergent there in this case and some lipid, but we can actually now begin to see secondary structure. So the question of is structure maintained without water in a vacuum, I think is beginning to go away. I mean, these may be very favorable because it's possible that this detergent mix is helping to keep them cool when they land, so we preserve more of the structure. So I think that, for me, I felt like I'd been validated when I saw those, structure at last, collected in the mass spec. And finally, huge team comes and goes, so all over the years, it's been a pleasure to work with my team. This is our new institute, and you see at the back, the peaks are the broad peaks that I started my career with, now etched into the wall. So I'm actually, this is my story. I showed them to the architect. These are my first spectra, and he went away and came back with that, so I'm absolutely delighted. I thank all of my funding, and especially the Louis-Jeantet Foundation. I'm delighted to have received this award and to have this opportunity to speak today. So thank you for your attention.
Thank you, Carol. I have to say you've had many peaks in your life. Do we have Howard?
Thank you. Very interesting. With the rhodopsin experiment, you have the retinol, which is somehow trapped in the membrane and can be released. This is due to the transition from trans to cis of the retinol. So it becomes like a I think it becomes like a saturated fatty acid with a structure like an unsaturated. Have you looked at membrane composition? Can you modify membrane composition and see if this affects the process?
It's a great question. I didn't go into the eyes. The eyes are from cows that were for consumption, so I didn't kill any of them myself. So they are dark adapted, so we cannot really do anything to control their membrane, but we can actually see membrane components and how they change. So that's a very good question. And we have seen in the kind of proximity to the signaling rhodopsin changes in the lipid composition, although we can't, manipulate the lipids too much in the cow. But there are changes, you're right.
Well, thank you very much. It was really, really inspiring. So I have a question that relates to the G-couple receptor. And so here you saw this association with phosphatidylinositol phosphate. Was there some cholesterol, or is it something that you can see with the method?
Yeah, that's a great question. So to get the GPCRs to actually stay folded, we always have detergent and cholesterol. So we add the cholesterol, but the PIP2 was in addition. And I've noticed in a lot of EM structures that are coming to the fore, there's a lot of cholesterol around, but there's also PIP2, so that's actually quite nice to see that coming through.
Oh, yeah, another question, yes?
And then in the case of the rhodopsin, could we dream to have then this structure landed on the EM grid at different time point and to capture them structurally?
That's even beyond my dreams. But yes, no reason. We're working towards that. We haven't actually seen anything captured within a membrane on the grid yet, but why not?
I don't know if it's a comment or a question, take it any way you want. It's you casually said you just popped it out of the membrane. It's, it's not something that happens so casually. How
yeah, that wasn't very scientific, I feel. So we did very many different ways there. We tried extrusion, we tried all the normal ways, we tried sonication, and then we also used quite a lot of heat and voltage. And heat and voltage seem to drive this into the mass spectrometer. And we're sort of wondering about the mechanism as to whether or not you have to have sort of charged regions on the surface of the membrane. Those proteins seem to do better in the mechanism than those that don't. But we don't really have a very good handle on that yet.
Any last question? If not, thank you very much, Carol. Okay, the next three speakers share one prize. They share the 2022 Louis-Jeantet Prize for Translational Medicine, and they're recognized for the design and development of mRNA-based vaccines that safely protect humankind against the deadly SARS-CoV-2 virus. And the first speaker is Ugur Sahin. He graduated in medicine from the University of Cologne in 1992 and then earned his PhD also from Cologne, studying immunotherapy against tumor cells. He then worked as a doctor of internal medicine, hematology and oncology, and then in 2000 moved to the University Medical Center in Mainz, also in Germany, where he's had several positions, leading positions. And then together with his wife, Ozlem Türeci, who will be the second speaker, he co-founded BioNTech in 2008 and has since served as CEO of the company in addition to his usual academic duties.
Thank you very much for the introduction. It's such an honor to participate in this outstanding event with so many excellent scientists and presentations. So we have 3 mRNA talks, and Katalin, Ozlem, and I decided to avoid that we have a single slide which is overlapping. So I will not explain everything. I will focus on cancer immunotherapy. Ozlem will focus on the mRNA vaccine development for COVID-19, and Katalin will talk about the history of mRNA development. So we started our research on mRNA in the mid of 1990s, aiming to develop cancer vaccines. And cancer vaccines are an idea which is around almost for 100 years, stimulating the immune system against cancer. And just to explain you why the problem is so extremely difficult, I defined the 3 key challenges for developing a potent cancer vaccine. First of all, even a small cancer consists of hundreds of millions of tumor cells. A macroscopic cancer is even of billions of tumor cells. So that means if we want to fight an existing cancer, we really need the same amount of T cells because the cancer is continuing to go. So the question is, how can we induce a really extremely potent immune response? The second is, we have heard today in several presentations the heterogeneity challenge of cancer. That means cancer happens due to mutations, a sequential acquisition of mutations, and thereby every tumor is different, every patient has a different cancer, and within the tumor we have a heterogeneity. If we want to tailor a vaccine to the cancer, because the cancer in the patient is growing, we need to establish a way of fast analysis and fast development of a personalized vaccine. So we have the fast manufacturing challenge. These were for us the 3 challenges when we started our mRNA vaccine research in the 1990s. We worked the first 2 years on DNA vaccines, realized that this is not going to work, and then shifted to mRNA because of the properties of mRNA. It's like DNA, natural genetic information carrier, but it is quickly degraded in the cells, which means that this is a good safety profile. It can be efficiently produced by in vitro transcription. And what we also liked, it came with an inherent adjuvant activity due to the stimulation of innate immune sensors. That was not clear in the 1990s. It was just clear that it is immune stimulatory. The work that we started was primarily stimulated by a work from Eli Gilboa's group. And they published in 1996 a paper in which they described the use of mRNA either extracted from tumor cells or in vitro transcribed, transfected this mRNA into dendritic cells and transferred the dendritic cells into mouse and later on in clinical studies and showed immune responses against the encoded antigens. So we were interested in the use of mRNA, but wanted to avoid the use of dendritic cells because this is cumbersome, and came up with the goal to develop an mRNA in such a way that it's potent enough to be directly injected and inducing an immune response. So that was our motivation in the 1990s, and we knew that we had to deal with a number of challenges. So to make an mRNA potent, one of the starting challenges is that if you prepare in vitro transcribed mRNA and use that for translation, a certain amount of mRNA will produce a certain amount of protein for a certain time, and then it's gone. At the starting time, we realized that this is relatively weak. On the other side, mRNA is immune stimulatory. It was discovered in 2004 that mRNA is stimulating toll-like receptors and thereby induces innate immune responses like interferon alpha. This is welcome, but the balance between translation and immune stimulation was in favor of innate immune stimulation, which meant too much immune stimulation. So how to shift this balance? And the way that we have gone is to increase the translation of the mRNA per unit of mRNA. For that, we systematically analyzed the elements, the untranslated elements of mRNA. This is a typical mRNA molecule with an open reading frame with 5' 3' UTR caps and poly A tail. And we systematically analyzed the impact of modifications of the cap of the 5' UTR, replace the 5' UTR, replace the 3' UTR, ask the question how long must be the poly A tail and what kind of other optimizations can we do. We analyzed this directly in human dendritic cells and found out that constellations that improve the translation of a starting mRNA, which is here the translational kinetics, with a number of modifications were able to increase the translation by modifying the poly A tail. We discovered modifications in the 3' UTR sequences that stabilize and increase the half-life of mRNA, and we identified cap structures that allowed us a prolonged translation. The important aspect of these findings were, whereas each individual improvement came up with 3 to 5, sometimes 10-fold improvement, combining these improvements allowed us an exponential increase of the translational potency, allowing us to see strong immune responses with relatively low amount of mRNA. This was the first part. The second important discovery was that we evaluated in a systematic manner which are the regions, how to inject the mRNA. The established injection routes were intravenous, intramuscular, subcutaneous, or intradermal. We tested also direct injection into the lymph node. And what we observed is when we injected the mRNA into the lymph nodes, we got dramatically stronger immune responses, resulting in a 50 to 100-fold reduction of the required mRNA dose. This is from the very first experiment showing the expansion of T cells, which are depicted here in red, after intranodal injection. Within 3 days, T cells that are present and marked here in red color were massively expanded after intranodal injection. We tried to understand what is the mechanism behind that and learned by using labeled mRNA here in red that a few minutes after injection of the mRNA into the lymph node, the mRNA is taken up actively by dendritic cells in the lymph node. We characterized these dendritic cells and found that these are the classical dendritic cells that stimulate strongly antigen-specific T cell responses, whereas other cell types in the lymph node did not take up mRNA. We researched the mechanism behind that and found that this is an active process. In this experiment, we just co-incubated mRNA without any transfection factor and dendritic cells, and could see that in a concentration-dependent manner, the translation increases. The translation is ultra fast, happens after a few minutes, increases within 1 hour. The mechanism behind that turned out to be macropinocytosis inhibition of the micropinocytosis completely abrogated the uptake of mRNA. This was in vitro, and we were able to show that this is also the case in vivo. Inhibition of micropinocytosis abrogated the translation of mRNA here with luciferase and completely abolished the immune response induced by mRNA. So the question is, how can we use this mechanism, this active mechanism, for systemic delivery of mRNA? Because intranodal injection was not the proper way to go. We started to systematically analyze lipid nanoparticles. Lipid nanoparticles were already used in the 1970s for the first time, but were used to deliver mRNA in a cationic fashion, cationic lipid configuration, because this gave the best transfection in vitro and in vivo. We analyzed different properties and physicochemical configurations of the lipid complex mRNA and found that when the mRNA was formulated in a more cationic manner, it transfected primarily the lung, and changing the composition of the lipids to a near neutral resulted in a transfection of mRNA in the spleen. And within the spleen, we found that this type of nanoparticles, which were optimized for a size of 300 nanometer, not only ended up in the spleen, but also in the lymph node. And within this lymphatic tissues, they were taken up by dendritic cells because deletion of the dendritic cell population completely abolished the signal. In the spleen, the mRNA is taken up in the marginal zone, where the immature dendritic cells are located, and we show that this dendritic cells, after uptake of mRNA, migrate to the T cell region and induce strong T cell responses. So now we had a configuration with a powerful optimized mRNA and a delivery mechanism directly to dendritic cells, resulting in innate immune stimulation just in time of mRNA delivery with interferon alpha secretion, which induce maturation and activation of dendritic cells and T cells, plus the translation of the antigen in these dendritic cells, resulting in very strong T cell responses. And this strong T cell responses for the first time allowed us to see immune responses against shared non-mutated antigens in a manner that we had not observed before in any type of preclinical studies, resulting in rejection of established preclinical melanoma models. We translated this approach into the clinical setting. So the finding is optimized mRNA plus lipid nanoparticles targeting to dendritic cells. And we use this principle for different types of vaccines. For cancer vaccines, inducing immune responses against shared tumor antigens. For cancer vaccines, targeting neoantigens. For cancer vaccines, for stimulation of CAR T cells. And if we replace the immunogenic form of mRNA by using a nucleoside-modified mRNA, and Katie will talk about that, we were able to induce instead effector T cells, regulatory T cells. And by using the mRNA and delivering the mRNA with an intramuscular formulation, we were able to get immune responses for infectious disease vaccines. Let's focus on cancer. In our first clinical trial, which started in 2014, we wanted to treat patients with this mRNA lipid nanoparticles. It was at that time the first clinical trial worldwide, and we had a lot of discussions with the regulatory authorities. They requested us to do a lot of studies, and in these studies we surprisingly found that the sensing of mRNA in humans are 3,000-fold more sensitive than in mice. So that meant that we had to go into a clinical trial with doses that were dramatically lower than usually done in clinical trials. So the first doses were even lower than the doses that we applied to mouse. And indeed, this was good because we observed that even with the lowest dose of 7 microgram, we got this innate immune response. This is the dose escalation of our first patient who received in the first week 7 microgram, 14 microgram the second week, 29 microgram in the third week. And as you can see, the innate immune response, interferon alpha, is dose dependent. And with the interferon alpha dose-dependent response, we got also strong expansion of T cells. For the first time, we were able to see and that such a vaccine is able to induce billions of T cells. So these are ex vivo analysis. That means blood is taken out from this patient and directly analyzed for the presence of antigen-specific T cells. There is no immune response pre-existing before and after repeated vaccination. We got in this patient about 10% of all T cells reacting with the encoded antigen epitopes. And we observed in a proportion of patients objective responses with shrinkage of tumors, either with vaccine alone or in combination with PD-1. So these patients were treated in 2016 and had received in the meantime vaccination for almost 3 to 4 years. And the patients who responded to the treatment are still stable, without additional relapses. So this is the use of a vaccine encoding a T cell antigen. Another application of the vaccine is to evaluate the vaccine to stimulate CAR T cells. CAR T cell treatments are highly successful for treatment of B cell tumors. Here in this applications, the CAR T cell expand and stay in the blood of the patient. For solid tumor treatment, CAR T cell therapy is so far not yet successful. One of the challenges is that the CAR T cells disappear rapidly and do not expand sufficiently. So we had discovered a tumor antigen, Claudin-6, which is not expressed in normal tissues, but expressed in a variety of tumors like testicular cancer, ovarian cancer, uterine cancer, and other tumors. And we're interested to use this as a target for CAR T cells and evaluated whether the activity of the CAR T cells can be further amplified by delivery of an mRNA vaccine, which encodes the antigen that is recognized by the CAR T cells. And we use the same formulation, delivered the mRNA encoding for Claudin-6 into mouse here, the staining in the lymph node, again in the marginal region, in the spleen, we were again able to deliver the mRNA to dendritic cells, CD8 positive dendritic cells. And when we have done the experiment where mouse was treated with CAR T cell alone, here is the number of CAR T cells in mouse treated with CAR T cell alone. When we combined that with vaccination, we got a dramatic increase of CAR T cell numbers, and with repeated vaccinations, we could keep up the numbers. So for what kind of purpose is this good? CAR T cell treatment are currently based on delivery of T cells in the range of 10 to the 9 or even higher numbers. The question is, can we reduce the numbers of CAR T cells that are delivered, and can we ensure a better safety profile, and can we ensure a longer engraftment of the CAR T cells? So this approach is in the meantime translated into the clinical setting. It's running first in human clinical trial in patients with testicular and ovarian cancers, and we see that this type of treatment results in objective responses, and in one patient we observed a complete response. This is a pretty early clinical trial, but shows that this patient population who do not have other options for treatment benefit from this type of treatment. And the doses that were applied here in this treatment are in the range of 10 to the 7 and 10 to the 8 T cells. Here's an example of a patient who received 10 to the 7 CAR T cells and received the vaccine. After infusion, we see a direct expansion of CAR T cells, and the CAR T cells drop over time. Repeated vaccinations are able to partially control the numbers and keep them up. And this patient had multiple metastatic lesions in the lungs and the liver, and developed an almost complete response after the treatment. The clinical trial is further ongoing, and most likely we are going to start a phase 2 study. So now back to the most important aspect that we are developing with our vaccine, personalized vaccines targeting neoantigens. So addressing the key problems of cancer heterogeneity. It is known for more than 30 years, and Ton talked about this and introduced this topic, and that mutations can form neoantigens recognized by CD4 and CD8 T cells. Actually, in 2013, Ton had published a paper providing a revival to this topic because it was one of the first papers showing that anti-PD-1 activity is associated with expansion of neoantigen-specific T cells. So we asked the question, what is the percentage of mutations that are immunogenic? It is well known for PD-1 treatment that this is about 1 to 2% spontaneous immunogenicity. But when we tested this in mice by identifying the mutations and evaluating their immunogenicity, we came up with a surprising finding that about 15 to 20% of all mutations induce an immune response if used as vaccine targets. So the concept that we wanted to develop is to analyze, identify all cancer mutations by next-generation sequencing, and then prepare an individualized vaccine that not only addresses some mutations, but ideally a set of mutations that allow to target all tumor cells, regardless of their clonality. So this is the concept. Relatively simple concept, but in the execution, of course, way more complex. We were able to show that this approach works in mice for multiple tumor models, identification of mutations using computational approaches, making an mRNA vaccine that has multiple mutations, and using this mRNA vaccine to evaluate the preclinical activity in tumor models. So this was in 2015, and we had in parallel started a clinical trial which uses this approach, and this pictures show how this approach works. What we get is from the patient the blood and the tumor tissue. We use the blood and the tumor tissue to extract DNA and perform sequencing to identify the mutations. The normal DNA serves as a template to identify the mutations, and the mRNA sequencing shows which of the mutations are transcribed in the tumor. Then we combine this with bioinformatic algorithms to predict those mutations which are expected to be highly immunogenic and presented on MHC1 and MHC2 molecules. Then, based on these predictions, we design a vaccine, and this vaccine uses the same vaccine backbone, which is optimized, but includes multiple mutations that are separated by linkers. We showed that this approach is able, in our clinical study, to induce vaccine-induced immune responses. So this is an example showing in an ELI spot that the patient did not have any pre-existing T-cell responses, and after vaccination developed T-cells against 3 of these mutations. And we were able to see that in this clinical study with 13 patients, all patients developed immune responses against multiple mutations. Several patients had extremely high number of T cells, and we were able to show that, that the mutation-specific T cells recognize and kill cancer cells. Most importantly, we observed that the patient population that were vaccinated had, before vaccination, multiple metastatic relapses here in red triangles, and after vaccinations had a dramatic reduction of metastatic relapses. Most of the patients still today are free of a relapse. So this was in melanoma, and of course the question is, melanoma is highly immunogenic and already well addressed by checkpoint blockade. The question is how this type of treatments work in tumor types which have a lower number of mutations, like triple-negative breast cancer, like pancreatic cancer or colorectal cancer, in which checkpoint blockade is not working or not very well working. So these are data in triple-negative breast cancer patients. We have essentially the same findings with a strong frequency of immune responses of high magnitude, including CD8 as well as CD4 immune responses. We see in these patients, these are adjuvant triple-negative breast cancer patients. That means patients after surgery, that immune responses not only developed in a high magnitude, but stay stable for a very long time, which is a great promise that these immune responses translate into the control of relapses. We have similar data in collaboration with colleagues from the Memorial Sloan Kettering in pancreatic cancer. Here, patients after pancreatic cancer tumor resection receive chemotherapy, and after chemotherapy receive the vaccine with one prior dose of checkpoint blockade. In this patient population, and pancreatic cancer is one of the tumor types that did not respond so far to any type of immunotherapy. It is one of the most deadly cancer types, and immune responses have been found, but the magnitude of immune responses in this patient population usually is at the detection limit. What we have seen that even in this patient population, we had 50% of patients showing high magnitude of immune responses with an average of about 3% of T cells ex vivo, some patients reaching up to 10% of T cells. And in this patient population, we saw that this patient population did not have any relapses after vaccination, whereas the patient population which did not respond with this immune responses has the same type of kinetics in developing relapses. So the question is here, how can we increase the responding patient population to 100%? And this comes with the question, which type of antigens are recognized? What are the features of mutations that are recognized by the immune system? Yeah? How can we select these mutations? How many of them shall we use? And this stimulates a completely new type of science, neoepitope prediction, yeah, which drives this type of question, not only for cancer vaccines, but also, as Ton presented, for T-cell-based therapies. Yeah? And there's a lot of progress and understanding in the field. So we have, for example, the understanding that clonality of mutations is an essential factor, yeah, for targeting, but also, for example, transcript expression level or similarity to foreign antigens turned out to be important. The exciting aspect is that currently we focus only on one type of mutations. These are single nucleotide variations. There are many, many other mutations, for example, gene fusions, indels, that seems to be even more immunogenic. So in this last slides, I would like just also to ask the question: what is the difference between checkpoint blockade and vaccines? And one of the clear aspects, the differences, is that checkpoint blockade primarily activates and expands pre-existing T cells. So here in this graph, we have the frequency of T cell receptors in a single individual who had received a vaccine, prior vaccination, almost not detectable, post-vaccination, massive increase of the T-cell receptors. But if you look closer, we see that many of these T-cell specificities are pre-existing in the patient, but were after vaccination just expanded. What is interesting is here this population, because this is the truly naive population. So that means T cells ignored these antigens, but with a vaccine, we can induce the de novo immune responses. And this is, according to our belief, really the most important factor of a neoantigen vaccine, because the majority of tumor antigens mutations are ignored. Only 1 to 2% of mutations are recognized spontaneously by T cells, and we believe targeting ignored neoantigens together with the preformed neoantigens could allow us to target tumors that are particularly have a lower mutational burden. In the last 2 slides, the process. So this is the process of making an individualized mRNA vaccine. Yeah? So when we started our clinical trial, this is an original slide from 2013, where we depicted the whole process, getting the tumor samples into the lab, extracting the DNA, extracting the RNA, quality testing the samples, doing the sequencing, identifying the mutations, prioritizing the mutations, designing the DNA template, preparing the mRNA under GMP conditions, and quality testing the mRNA and shipping that back to the study. So this is the selection of processes that were needed, and we had, before we could start the clinical trial, an audit to check the quality of this part. And this is our co-worker preparing for the audit, yeah, with all the documentation needed at that time, yeah. So the audit went well, yeah, and we were authorized to do the clinical trial. And every patient, of course, gets an individual vaccine, which needs to be prepared under GMP conditions. Every preparation is about 1,300 pages of documentation, yeah. And we did this process in the meantime for hundreds of patients. Of course, not using the old approach from 2014, but we established digitalization, so no paperwork anymore. Everything is on a computer, and we implemented semi-automation, which reduced the time to deliver a personalized vaccine to less than 6 weeks. That means we have now the technology in place to rapidly develop vaccines that are tailored to the mutanome of the patients. We don't believe that these approaches will change the fate of advanced cancers, but we believe that this type of approaches have a high likelihood to work in a high medical need situation. That means patients after surgery. We know that depending on the tumor types, about 20, 30, up to 70% of patients after surgery have relapses. And there is no treatment for this patient population to reduce the relapses. The usual treatment is chemotherapy. And the question is, can we implement personalized vaccine after surgery, receiving the tumor, and then making a vaccine personalized and ensuring that the immune cells are able to target the residual tumor cells. So I end here. I would like to acknowledge the funding that we had particularly in our early academic times, yeah, from the German funding institutions, as well as from the European Research Council. And of course, I would like to thank my co-workers. There are now many involved in this type of studies, but I would like to explicitly mention Sebastian Kreiter, Mustafa Dieken, Jan Diekmann, Matthias Former, and Lena Kranz, who were at the beginning and served as PhD students and postdocs, And I would like to thank our clinical collaborators as well as our partner, Genentech, with whom we are developing now this vaccine. Thank you.
Thank you for that very nice talk. Questions? Patrick?
Wonderful, thank you. I was wondering about the, mRNAs that you now have with multiple coding sequences to target heterogeneity. There must be some kind of limit for the length of the mRNA because you need to package it, to manufacture it, to deliver it. Do you see any limits there?
Not limiting this approach. So there are examples of delivering mRNA of 12, 14, 15 kilobases, and if you work hard, even longer. Yeah. So this type of cassettes are in the range of maximum 3,500 base pairs. So we are not at the limit now.
For those patients whose tumor escaped to the vaccine, even when you combine different mRNA, did you look into whether they would express other neoantigens or whether they would be resistant to T-cell mediated killing? Because this is known that tumor cells tend to be less sensitive to fast mediated killing.
It's an excellent question. So I would like to mention two cases. We had one case in our melanoma study where a patient responded to the vaccine, and this patient had wonderful T-cell responses against multiple epitopes, and then she got an relapse and got after the relapse anti-PD-1 treatment and died, and we were of course frustrated because this patient had a strong immune response. And then we got the tumor and analyzed that and learned that the tumor lacked both alleles of beta-2 microglobulin. So that means this tumor was not able to present anything anymore to T cells. So this provided an explanation. And a recent finding was a relapse in our triple-negative breast cancer study. And the patient had also strong immune responses, but developed a relapse. We analyzed the relapse and found that the relapse was a completely different tumor. The patient has a BRCA mutation, and that means that this patient had multiple existing tumors. And of course, if they are independent, the vaccine will not work.
Great stories, thank you very much. I have a very basic question. You told us that the mRNA enters the cell through macropinocytosis, and that makes a lot of sense and is convincing. Yeah. But how does it get from the macropinosomes into the cytoplasm? Do you know that?
This is an excellent question, and no one knows that.
Do we know what determines the specificity of dendritic cells taking it up?
The dendritic cells are specialized to do constitutive macropinocytosis, whereas macrophages do that only after stimulation.
And CD11 knockout does what?
CD11 knockout depletes all APCs. And yeah.
Thank you very much. Yes. Okay, the second of the three speaker set is Ozlem Türeci, who graduated with a degree in medicine from University of Saarland and then earned her PhD also from the University of Saarland. As I mentioned earlier, she co-founded with Ugur the BioNTech in 2008, where she led the project that developed the now famous mRNA-based vaccine against SARS-CoV-2. She is also currently the chair of the German Cancer Immunotherapy Association.
So thank you very much for this kind introduction, and I feel honored to be one of award winners of this prestigious award, together with my colleagues who were speaking here today, and also to speak to this very distinguished audience. I would like to pick up exactly where Ugur left. By the end of 2019, we had built a diversified mRNA toolbox and had used our mRNA technology in clinical trials and learned how to manufacture for human use for clinical trials. So that at that fateful last weekend of January 2020, when we realized that we were actually already in the midst of a pandemic with a novel virus, we felt the obligation to try to contribute with our technology to the response to this virus. We were not sure whether we would succeed, but you know, this is how scientists act, that they feel the obligation to provide their science for such a purpose. We called the COVID-19 development project Lightspeed because we thought that time would matter. We started right away with the design of 20 different mRNA-based COVID-19 vaccine constructs, which we tested preclinically, and chose 4 of those for a phase 1 trial, which started only 3 months later. Our phase 1 data allowed us to select one of those constructs, one of those candidates, BNT162b2, aka Comirnaty, for phase 3 testing in July 2020. And in November 2020, 11 months after we started the program, we had our vaccine efficacy data from a global phase 3 trial in 44,000 participants, which showed us vaccine efficacy against symptomatic disease to be 95%. We had, as you always do if you are in a desperate situation, planned for success. That meant we had initiated early on cooperation with our partner Pfizer in order to complement our skills with their skills of globalization of large clinical trials and of supply chains. We had early on also partnered and interacted with regulatory authorities in a very close dialogue to ensure that we would deliver the data packages which would help them to assess our vaccine. So that end of that year, we received authorization for this vaccine, which could be rolled out. Today, more than 1 billion people have been vaccinated in more than 170 regions. As I already pointed out, we started off with 20 different vaccine candidates because there were so many unknowns. Back in those early days, there was a lot of concern about enhancement of disease by vaccination, and therefore we did not only use the full-length spike protein of SARS-CoV-2, but also a fragment, the RBD domain, which both were reflected in our panel of candidates. We used 2 different types of mRNA chemistries, the uridine-based mRNA, which Ugur has already described from our cancer vaccine trials, but also nucleoside modified mRNA, which blunts the innate immune stimulation, because we had to combine here with a different lipid formulation for LMP forming, which could be used via the intramuscular route, not the intravenous route, which we were using in cancer vaccines. The candidate we choose in our phase 1 trial is BNT162b2, has the full spike protein, which is conformationally stabilized by mutations to have an erect RBD domain, the binding domain to the ACE2 human receptor. It is nucleoside modified because that combines best with the antigenic adjuvant activity, bringing intramuscular LMP combination, and it has all the non-coding element modification, which Ugur has already described to you. We had to, as I said, change our mRNA LNP formulation and use different LNPs for IM delivery. However, we used for designing these particles our knowledge about the leveraging of macropinocytosis to design these particles, and achieved exactly what we wanted, namely uptake by lymph node resident dendritic cells. On the upper panel here, you can see RNA in situ analysis, and the lower panel shows IHC staining, the first one of the administered mRNA, the second of the protein, which is encoded. And as you can see, even though we inject into muscle, we don't see uptake of the mRNA by the muscle and no expression by the muscle, but rather uptake of mRNA and expression of a protein in the draining lymph nodes and in lymph nodes beyond that. It was important for us, and that was also considered in the design of our specific mRNA, to induce not only an antibody response, which is always a very important endpoint in pharmaceutical development of vaccines against respiratory viruses, but also induce a strong T lymphocyte response. As cancer vaccinologists, we believe in T cells and what they can do, and have expected that in particular for severe disease and hospitalization and death, the T cell part of the response would be important. We saw in our mouse experiments that we got both. We got high levels of spike binding antibodies with robust neutralizing capability after a single IM injection. And we also got T cell responses, both CD4 cells of the Th1 phenotype and interferon gamma IL-2 secreting CD8 antigen-specific CD8 cells. And this could also be confirmed in the human setting. Here data from our phase 1/2 study, where we, however, needed 2 doses, so a prime boost initial series for vaccination, 21 days apart. Immunologists would have preferred a longer time interval between both injections, but you know we were in a pandemic and time mattered. We saw that at a dose range of 10 to 30 microgram per dose, we already got antibody levels, binding antibodies and neutralizing titers, which were very robust and which were comparable or higher as compared to human convalescent sera, marked as HAS here. And on top of antibody responses, we could show that in the same dose range, we were able to induce CD4 and CD8 T cells, which were comparable to recall immune responses to frequent pathogens like CMV or EBV. And this dose level shows that it was worthwhile in those 2 decades before to optimize for potency. This all translated into vaccine efficacy. On the left-hand side, you see our initial analysis with 95% efficacy against symptomatic disease across all age strata, including in participants of 65 years and older. And in a follow-up analysis, 6 months later, we could show that vaccine efficacy against symptomatic disease was still at 91%, with 97% efficacy against severe COVID-19. Now, if you have never seen before new virus, a pandemic, the mission is not yet finally achieved with developing the initial vaccine. Therefore, in order to stay actionable, we decided to follow the virus and its further development. At that time, there were many unknowns. Questions were how long would the immune response last, when would it wane, and would there be immune escape variants? And obviously, these two questions are strongly entangled. So one of the things we did was to screen the newly emerging mutated sequences. You can do this sort of manually, but we decided to make use of AI, artificial intelligence, and machine learning, AI/ML systems, and set up an early warning system, which was based on structural modeling analysis and natural language processing in order to assess the virus fitness, which means transmissibility and binding to the ACE2 receptor, but also its capability of immune escape based on altered antibody epitopes. In the middle part there, you can see that we were able with this system to identify VOCs, variants of concern, before they were even declared by the WHO. So this meant that we could be actionable. The first couple of variants, the alphas and deltas and so on, did not concern us too much when we analyzed altered antibody epitope profiles. The first one where we were not really alarmed, but a bit concerned was the beta variant, where you can see in the red color code that epitopes were already altered. Real concern, however, meant Omicron. This is the third one there in the panel, where we saw very strong alteration of the antigenic determinants. And when we analyzed the sera of BNT162b2 vaccinated individuals after the second dose, so the primary two-dose series, for their capability to neutralize in a pseudovirus assay, neutralization assay, those different virus spikes which are listed there, you can see that this was easily feasible for all those vaccine variants, for all those virus variants which had occurred, but not for Omicron, at that time BA1. And also the same data on the left-hand side. After 2 doses, no neutralization of the ancestral virus, Wuhan Hu1, but not of the BA1 spike. However, when we vaccinated the first time, so the third booster, we could elevate the neutralization titers to robust and high levels, and we directly communicated this so that regulators also recommended emergency third booster administration. However, as you can see on the right-hand side, whereas the third booster is very nicely neutralizing against the Wuhan variant, or even 3 months after the third booster. This is not the case for Omicron BA1, and the immune response, the neutralizing capability wanes. Not only the neutralizing capability, but also the protection from symptomatic disease. This was shown by real-world data. The black symbols there is delta and the kinetics of protection from symptomatic COVID-19 disease after 2 doses and after 3 doses, which, as you can see here, is pretty robust, which is not the case for Omicron BA.1. So booster vaccinations with the ancestral vaccine with BNT162b2 are an option as a band-aid, but not something which is sustainable. And therefore, we embarked in developing variant-adapted vaccines, which were adapted to the BA.1 variant. We started with that already in November last year, as soon as we got the data from our early warning system. What exactly does this mean? This basically only means that you exchange the encoding sequence which is in BNT162b2, the Wuhan spike, against the BA.1 spike, which, as you know, is in the large part of the sequence identical except for the mutations for the original spike. And we used 2 versions. We had monovalent Omicron BA.1 adapted vaccines and bivalent, where we mixed the wild-type spike vaccine, our original spike vaccine, with the BA.1 exchanged vaccine, and started discussions with the regulators worldwide. We offered to be ready for vaccine supply within 3 months. That would have been March this year, if we could agree on using CMC data and preclinical data for vaccine approval. Regulators wanted to see clinical data, which means that you have to do a clinical trial, which we started. And by July this year, the clinical trial provided us with data for neutralization of BA.1, and as you can see here, these are neutralizing titers, mean geometric titers for neutralization of BA.1, comparing pre-vax. These are subjects who had 2 to 3 vaccinations with the original vaccine and received then the variant-adapted vaccines and were investigated pre-vax with Omicron-adapted vaccines and 1 month after vaccination. And as you can see here, with both versions of the Omicron-adapted vaccine, we could get a robust and higher titers as compared with the original vaccine. However, as you know, yes, this clinical trial achieved its endpoint, but in the meantime, the virus had not waited for the vaccine, but had further evolved, and we had a dominance in the meantime of the Omicron sublineage BA.4, BA.5. Both have the same spike sequence, therefore they are sort of called BA.4-5 for this purpose here. And BA.4-5 spike is strongly mutated in both the NTD region as well as the RBD region, and is antigenically different as compared to BA.1. And in line with this fact, when comparing the neutralization of the Omicron sublineages by sera of subjects who were originally only immunized with the BNT162b2 vaccine, we could see that the BA.4, BA.5 spike is even less neutralized as compared to BA1. And this also is supported by real-world data. This is real-world data of hospitalization due to COVID-19 at a time when BA4-5 were circulating, and repeating boosters with the original BNT162b2 was not able to control hospitalization. And again, in line with this, the sera we had generated in our clinical trial with the BA1 variant-adapted vaccine showed that there was some robust neutralization also of BA4-5, but clearly lower. So the question was, would it make sense to develop a BA4-5 vaccine in order to address the immune escape by BA4-5, a mutated virus? And there is a way, in absence of clinical trial data, to get a feel for that, namely to use a sera of BA4-5 convalescent subjects, because they have been exposed to the spike we are interested in, and therefore we initiated such studies in order to learn about the effect of the exposure to BA4-5 spike of an immune system which is shaped by BNT162b2 vaccination. And we used sera and also memory B cells actually to investigate this for subjects who were either double or triple vaccinated with BNT162b2, the ancestral vaccine, without breakthrough infection, or had breakthrough infection after that with Omicron variants. And this is data now for subjects who had breakthrough infections after double, triple vaccination with BNT162b2. And these breakthrough infections were with Omicron BA1. This is analysis of memory T cells, and we used bait technologies using spikes which were either directed against, which were either encoding the Wuhan spike or the BA1 spike, in order to deconvolute the immune responses. And what we observed by combinatorial analysis was that the circulating memory B cells of subjects who have had BA1 breakthrough infections after vaccination with BNT162b2 were primarily directed against conserved epitopes across these variants, but only a few, a small number were directed against specifically and selectively Omicron BA1 specific epitopes. What did this mean for neutralization activity of sera of these patients? On the left-hand side, the green symbols show serum neutralizing activity and cross-neutralization for all the variants which are shown here in a pseudovirus neutralization assay. And on the right-hand side, after breakthrough infection with BA1 on top. And as you can see here, whereas the breakthrough infection with BA1 induces very robust cross-neutralization of BA1 and also BA2, this does not work for BA4-5, much in line with what we had observed in our clinical trial. This now are investigations of neutralizing titers with subjects which had, after vaccination with BNT162b2, breakthrough infections with BA1. That's the purple symbol, BA2, the blue symbol, and BA45, the orange symbol. And as you can see, whereas breakthrough infection with BA1 does not neutralize well against BA45, breakthrough infections against BA4 with BA4 or 5 do this very robustly. And we investigated this also in mouse experiments. What would happen if we would vaccinate mice with BA4 with BA45 variant-adapted vaccines, both bivalent and monovalent, after a series of BNT162b2 vaccination. And again, here we confirmed that we were able, by doing this, to get also robust immune responses against BA4 and BA5 in double vaccinated mice, but also in mice which were previously unvaccinated with BNT162b2. And this motivated us to discuss, to present our BA45 vaccine, which we had developed in parallel at risk, also to the regulators, and talk with them about the fact that new regulatory pathways are required if you want to change your vaccine and adapt your vaccine according to the fast pace the virus has. Vaccine regulatory pathways where one would not need clinical trials for primary approval, but would provide the data later. There were also non-scientific challenges which we had when developing this vaccine. As you know, scientists sometimes also have to face them and have obligation to address them. We did. One of these challenges was the supply challenge. When we focused on cancer vaccines, we did not need much manufacturing capacity, understanding that for providing vaccines for a pandemic, we increased our vaccine production capacities, but also the scale. And sometime in 2021, we realized that only few of the companies who initially started to contribute to pandemic response would be able to, in fact, contribute with their vaccines. We felt the obligation to even upscale more. The scale-up factor at the end was more than 300,000 in order to really ensure that we could deliver. And you can imagine that also for this, innovation was required. And my last piece here, another non-scientific challenge was that we realized that there was the challenge of non-equality of vaccine distribution. The first thing we did as a sort of band-aid was to deliver at cost to low and middle income countries. So 40% of our vaccine production in last year went at cost to those countries. But you know, that is not sufficient, and we expect that we will face the pandemic and this virus for quite some time. Therefore, one of our plans is to enable people in low and middle income countries to produce their vaccines in their regions for themselves, which means technology transfer, which we feel is not an act, but is an attitude and means longer-term commitment, because mRNA vaccine production is complex. Many steps, many quality assays, etc. And for this purpose, we have generated a container-based system, which we call BioNtainer, which we want, first of all, to provide to the African continent, and we are working together with the African Union, the WHO, the European Commission. For this, we had the first groundbreaking for the first BioNtainer a couple of weeks ago in July in Kigali, and we plan to install the first bioantenna at this place in beginning next year. What exactly is a bioantenna? It is a container-based system which comes with its entire infrastructure and air purification and IT controlled production. It's set up and equipped and pre-test run in Germany in our facilities with quality check and test runs, and can then be transported by train or by ship to the respective regions. As already pointed out, Kigali is the first place, and places in the Senegal and in South Africa will follow, and there the containers can be set up with local qualification runs with the regional authorities and can be operated. The operation is semi-automatic and digitalized, which means that whenever we update the process or have a variant-adapted vaccine, this can be fastly accommodated also in these places. With this, I would like to thank you for your interest and acknowledge all those who were involved, including those Ugur has already acknowledged, because all those 20 years of development for mRNA cancer vaccines went into this, and this is only the tip of the iceberg of all the wonderful people who have supported this vaccine development.
Thank you, Ozlem. All I can say is hooray for science. It was amazing. Questions?
So thank you for this presentation. I just have a question regarding your sample number with the bulb C animals. The slide where you showed the rationale behind deciding to go for a second and a third dose. And I come from the behavior field, so I was a bit surprised that the sample number of the animals was in one round 8 and another round 5. And I'm just wondering if that's let's say standard in this sort of research, or was this an exception made given that it was a pandemic?
So this is just one of many experiments, also with larger sample sizes.
In the back.
Yeah, thank you. I was wondering, when there is a chronic stimulation, T cells are getting exhausted. So what is the impact of multiple vaccination, including with the same variant or with different variants, when you're getting 3 doses, 4 doses of vaccination, with regards to T cell activity, T cell exhaustion? Do you have data on that?
We don't have follow-up data yet with regard to T cells. Therefore, we have not analyzed them after a longer time and after so many boosters. But we see that we can retrieve T cells after 3 months, for example, and they are boostable. But we certainly need more data. From our cancer vaccine trials, where we have multiple boosters in principle in patients with advanced metastatic disease, we booster them every 6 weeks to 8 weeks for a longer time. We have data which shows that T cells are not exhausted, but we have to reproduce the data with this specific vaccine platform we have used for COVID.
Thank you for this impressive presentation. I have more general question concerning the next pandemic virus. Do you have any development for influenza or against influenza viruses?
Yes, we have. We are using with our partner Pfizer the same platform to develop an influenza vaccine that is in clinical testing, and one of the development paths is that we want to combine with the COVID-19 vaccine. It's the same platform, and we can easily accommodate multiple antigens in the same formulation.
Thank you. I have two small questions. Do you see your particles also going to the liver? Do you think there's also a reaction taking place here? And the other thing, could you comment on other applications such as the nose, inhalation, vaccinations, or even PO's GI applications?
Yeah. The particles in the liver? Yeah, no, in animals we don't get expression in the liver. In humans we obviously did not look. And the second was nasal, for example, application. Yes, we are working on alternative routes of application, including nasal. Need the right formulation for that. That will take some time.
Okay, no further questions. Thank you very much. Okay, we have the third and final speaker of the 2022 Louis-Jeantet Symposium Prize winner, which is Katalin Kariko. Katalin graduated with a degree in biology from the University of Szeged in Hungary in 1978. And then she also did her PhD studies, in this case in biochemistry, at the University of Szeged. She was a postdoctoral fellow at Temple University in Philadelphia, where she continued to pursue her therapeutic possibilities of RNA. And in 2013, she joined BioNTech, where she currently holds the position of Senior Vice President. Katalin.
Thank you very much for awarding me this very precious prize, and congratulations to the fellow awardees. And I am happy to be here, and you heard about where the RNA can take you, and I am telling you how we get there. So a little bit backwards, but many people thought, didn't hear about, mRNA, but they thought that all of the therapy came just like an overnight phenomenon, and I can tell you that there were many, many years of overnight we worked on it. And mRNA was discovered in 1961, and it took 60 years when first we have this FDA-approved mRNA medicine in the form of COVID-19 LMP vaccine. During these 60 years, many, many things happened. I will just pinpoint a couple of things which I think that it is important for you to know. From isolation of the RNA, later synthesizing the RNA, optimizing, and I can say right in advance, the 60 years, most of them is an incremental increase, improvement of the RNA and the delivery system. That's how it happened. So the RNA was discovered in 1961. Two papers describe, interestingly, both of them saying that it is unstable intermediate. They were looking for years, and I don't have time, I just have limited time, so that I don't say about how much effort was done to actually just identifying the RNA. But with this one, we learn that what is the information flow is coming from the DNA. I have a pointer here, the DNA, mRNA, and the protein. Of course, scientists identified and they could isolate RNA, and that's what they start to investigate. So they first investigated and looked at the structural chemist, that what this RNA, what kind of structural elements there. Actually, in 1971, they discovered the RNA has a long poly-A tail. 1975, they identifying that at the other end of the RNA, we have this special cap structure. Actually, here I am showing Türeci, who first described, actually, just Friday he passed away. I was lucky to meet him in Japan this year. And so he was the one who proposed and then came to the United States and demonstrated, that not just the viral RNA, at that point people just could isolate viral RNA or mRNA because they already oligo-DT, they know that poly-A tail exists, they could look at, and they found that both viral, both the mammalian RNA has this very special 5' structure. At the end of 75, Bernard Moss and colleague actually also identified that viruses have special enzymes which can cap, and if you get the Moderna vaccine, this is the enzyme was used to put that cap on the RNA. Other scientists were working and, again, isolate the RNA. They used the reticulocyte because they are enriched in beta globin. And what they did, they tried to see that whether they can translate that RNA. They tested on cell lysate, they injected in frog oocyte, and interestingly, early on, 1978, they already used liposome and put the mRNA, which was isolated from this reticulocyte, and delivered in mammalian cells. And it was primary cells, and they demonstrated that the protein, which otherwise these primary cells would not make, they could make. So this was, for me, 1978 was an important date, and this experiment, Dimitriadis and Ostro, they made in England, and the other in the US. And we're in Hungary, was reading this paper with my colleagues, my supervisor, and decided that we will make also liposome, but we didn't isolated RNA, rather we just made the simplest way, just deliver plasmids. And we couldn't even purchase this so-called forced reaction file because we were behind the Iron Curtain. So Ernő went to the slaughterhouse, came back with a co-brain, and we followed a protocol how to isolate the special phospholipids. But why students are here, I'm just saying, I was an undergraduate student, and this was first we delivered a nucleic acid inside the cell, and it is important just to make your hands wet and try to do something, and then maybe rest of your life thinking about that experiment and further develop. So after the lipid lab as an undergraduate, I went to the RNA laboratories, not by my choice, just Jenő walked in one day and he said that he can take students, and I was there ready. And actually, he's organic chemist, and he made CAP analog, who he sent to Türeci and others at New Jersey to have a reference material. So when I started there in 1978, I knew that RNA has a CAP. And, but my role was to synthesize this oligoadenylate and work together with János Ludwig. Another message for the students here, because even today I ask every organic chemistry question from János. So it is good that you're a fellow student, you just, be nice to them and you can ask and they will respond. So anyway, my first project was to develop an antiviral compound. 1977, Ian Kerr just discovered this 2' 5' linked oligoadenylate, which activates an RNase and so on. And so I have to set up antiviral assay and also synthesize this molecule. And so this molecule normally, double-stranded RNA-induced oligoadenylate synthase is producing, and then it activates RNase L, which cleaves RNA and degrades the viral RNA. At that point, we thought that this is the antiviral mechanism of the interferon. I might mention here that those people who have a low level of OAS, those were during the COVID, they get very serious infection and side effects. So you can see that the double-stranded RNA activates that. This is an RNA. It cleaves an RNA. So everything was about RNA and their degradation, what I was doing. So coming to the United States, again, I still worked on these RNA molecules, but eventually we couldn't make it and use as a medicine. So when coming in 1985, in US it was 1986, the problem was the HIV, another viral problem. And so together with colleague at Temple University, we developed a double-stranded RNA, a mismatched double-stranded RNA, and we treated HIV patients. And this was published in 1987. This mismatched double-stranded RNA was demonstrated that activates TOR3, but that didn't come just 20 years later or 2001. And unfortunately didn't help the patient because their interferon system was compromised. But while I was doing this kind of RNA work, other scientists worked and made a very important discovery, how to synthesize RNA, very simple way. We heard about Patrick telling that how complicated is making RNA, with our mammalian system. But scientists at Harvard University, Paul Krieg, Douglas Melton, Maniatis, and others came up with using a simple RNA, the phage RNA polymerase, to make RNA, and is using just a template here, from plasmid, but it can be a PCR product that PCR just come, much later. And providing just the basic nucleotides, the enzyme, and they also get from capping enzyme at that point, and they made RNA. This RNA had cap, it has coding sequences, poly-A tail, and transcribed from this structure. Actually, again, mention something. I sent a letter to Paul Krieg that I would like to make and use this template, and he put in an envelope and sent it to me, and sent also another one. He said that we made a better one now. It is T7 RNA promoter, and you work with the T7 RNA polymerase. And just to say that at the beginning, how generous fellow colleagues were. There were no MTA was signed. And so they made this RNA coded for interferon, and what they did is injected to frog oocyte. Again, if you are about my age, you know that all genetic lab had already a frog there because their egg was large and it was easy to work with. And so after injecting and culturing these oocytes, they harvested the medium and they found that that was functional interferon. So this was, again, a very important milestone. And why it was important? Because it inspired so many people to start with work with RNA. And so it started in 1990. I show here that maybe every year there was a paper, so it was easy to follow. And not like in these days that maybe every day more papers is coming out on mRNA. And one was this 1990 when they injected to the mouse and demonstrated that this luciferase mRNA was translated in vivo. Wolf and colleague did in. And then in 1992, this was a very important paper for me because I was interested to develop mRNA for therapeutic purposes. And this was when vasopressin mRNA was shown that how it can treat a rat, a Rotterdam rat, which has a special diabetes insipidus, they call it, and that after injecting a very small amount to the brain of the animal, the animal was treated. Subsequently, 93 and 94, messenger RNA was used for vaccine, infectious disease vaccine, and Martinon was the first one who published this, and he used liposome. The team used liposome, delivered mRNA, coding for the influenza-specific antigen, and similarly, Lerstom, he used the self-amplifying RNA. And Somehow after that, you do not see many papers who would focus on infectious disease. But what was more is about cancer vaccine. And one Condré and David Curiel and colleagues, in '95, they injected naked RNA to the tongue of the mice and they induced cancer vaccine. They demonstrated it. And then, what Ugur already mentioned, Eli Gilbo and colleague, '96, they were the first, established the first RNA company. They did human trial and so on and so on. But most of the other scientists never published another paper on that mRNA field. And the reason is because, you know, the RNA amount was very small and it was just a very short period of time produced because it degraded, and so seems like it is not useful. It will be not useful for any kind of therapy. So what happened in subsequent years is that improving the RNA, the messenger RNA, purification, structural element, the cap was improved, and Ugur mentioned many other elements, the untranslated region and so on. And of course, formulation, different kind of formulation. Here I just mentioned the lipid formulation, which sometimes happen together with the RNA. And this is how the 60 years happened. And what I was first time I started to use RNA is when I joined University of Pennsylvania, and Elliot Barnett hired me and he was interested in urokinase receptors. And since he was just 8 days younger than me, I convinced that mRNA is the way to do. And so cloning the urokinase receptor and delivering to the cells. What was interesting is that urokinase receptor, to be functional, it has to have modified post-translationally, glycosylation, GP-Eiling, and so on. And voila, we just put the RNA there, and we get functional receptor. And so we get very excited by that, and we thought that maybe the RNA will be very useful, maybe if nothing else for just therapy. But I had to go because I wouldn't be here. Many times I mentioned, several times I would not be terminated in my position. So next one was I had to go to another department, and this was neurosurgery. So the next 17 years I worked at that bench here and did all of the RNA work. And here I worked with a neurosurgeon who was describing me different kind of problem he's encountering when try to treat a patient. And that's also very interesting because every time I work with people who were expert in something else, whether it was an organic chemist or a cardiologist who was seeing a patient and coming with the problem, and then we try to see that, I understand the problem, try to see help, and how we could together develop something which is helpful. So we were doing different things. Most of the study we did nitric oxide synthase because we tried to dilate vasoconstricted blood vessels. And again, things changed. And when David left, actually, that's when I met Drew Weissman and looking for a new project. And Drew was interested to develop a vaccine, HIV vaccine. He just came from Fauci's lab and he wanted to make a HIV vaccine, a therapeutic or prophylactic. And of course, I immediately offered him that I will make mRNA for him. And this was encoded GAG protein. He used human dendritic cells, and we are in 1997, so it was a very novel thing. And when he delivered the mRNA, all of these important factors were upregulated in the disease, and also a lot of protein was made. And he also detected TNF-alpha, inflammatory cytokines. He was very happy with all of these things because, as Ugur already described, how important that the RNA has inherent immune activation. I wanted to treat, patient who has already had a stroke, and that was the last thing, to have more TNF-alpha. So we were thinking that why it is, where is this TNF-alpha is coming, why it is inflammatory. I was convinced that the RNA I am making is just as good as is inside our own cells, but then we thought that maybe even if our mammalian RNA would be taken out and due to the injury maybe and exposing the dendritic cells, maybe that would be also inflammatory. So to test that, we did the experiment, what I just mentioned. We isolated RNA from different compartments of the cells and treated dendritic cells and measured the TNF-alpha. Iron is a purple here, that is the RNA I made in vitro, and all of this other was not as inflammatory. And much less inflammatory, but all of this is related to the RNA, because when we digested with RNAs, there were no inflammation. And interestingly, tRNA was not inflammatory at all. So, of course, tRNA is very different than RNA I'm making. It is much shorter and different ends, but definitely we knew about that it has a lot of nucleoside modification. 25% of the nucleoside is modified in a tRNA. So the idea came from this experiment. Could it be that if we have modified nucleosides, then we can have non-immunogenic RNA? Of course, the first thought that how we should prove that. I have to say here that first ordered RNA, synthetic, where it was incorporated some modified nucleosides, which was commercial available. It was $5,000 order. And we tested out, but kind of even the RNA which had no modification, it was not immunogenic, so whether it was short and other things. So we have to decide that we have to make them different ways. And so it was known that there is more than 100 modified nucleosides in RNA. Just show this structure just here. And how these are incorporated to the RNA, what are the enzymes, were unknown. So you just couldn't order from Promega and test it out. So the only thing it was known at that point is that two modification, how it incorporated and how it is generated inside the ribosomal RNA. And again, a fellow student, Tamás Kis, who is University of Toulouse, discovered the 2'-methylation, the pseudo-uridylation. Again, the students, so follow those fellow students, what they are doing on the line and when they leave the school, and so if you call them and ask help, so they respond. And of course I told Tamás, that can you send me those stuff, and because I have to modify the RNA, but of course reading the papers, it needs special structures. So I had to call again János, who was fellow student, and ask him that, okay, we might have to do differently. We might have to purchase modified nucleoside triphosphate and try to see that whether T7 RNA polymerase were incorporated. So he recommended where should I purchase, and what I purchased these 10 different ones. And of course, we didn't know that whether T7 polymerase will incorporate, but 5 of them did incorporate it. And of course, we didn't know that whether we need all of these modifications which was present in the RNA, or one of them is sufficient. But we generated RNA, and all of the corresponding nucleotides was replaced with the modified one. And when we tested out similarly what we have done in the isolated RNA, what we found is that some of the RNA which had modification were not inducing any TNF-alpha. Here, you can see in blue now that which is an unmodified one, and some of the modified containing was still inducing, but not these. And when we made a closer look, we found that all of them were uridine modified. So it seems that nature selected uridine, to modify, and then somehow such RNA became non-immunogenic. At that point, we were, we published in 2005. When we discovered this in 2004, it just came out a paper demonstrating that toll-like receptor 7 and toll-like receptor 8 is activated by single-stranded RNA. One of them showed that poly-U was also effective to activate, but subsequently, actually 10 years later, we learned also that not the single-stranded RNA, but the nucleosides, which is generated in the endosome of the immune cells, the uridine and actually the guanosine. So the nucleoside can activate. Here in Toll-8 is shown that how these degraded RNA product, the nucleosides can activate and the crystal structure showed that, again, that's how you generate these nucleosides. All of the enzyme, the RNases, the RNase 2 and the T2 RNase. The RNase 2 is the EDN and the T2 RNase. These are the two enzymes needed, and they are working just in a low pH in the endosome, in this immune cells. That's how you activate. Anyway, so we want to, of course, to make an RNA which will be translatable. And when we test it out, luckily, some of them is translated, and pseudouridine containing RNA, we get 10 times more protein. So this was like an icing on the cake, that now that not just we have a non-immunogenic RNA, but now we get so much protein from it. So we spend the next couple of years try to find out why and how. But again, I just mentioned to you that, again, 10 years passed, and when you learn that actually our mRNA also contains pseudouridine. At that time, when we discovered and incorporated, it was not known. Even in this year, in January, we already can read that what is the function in our mRNA to get pseudouridine, for example, changing the structure, and if it is present there, then it will be alternative splicing occur, and so on. But after discovering that we can make mRNA which is non-immunogenic, we did what usually in the United States you do. You file a patent, you establish a company, and you apply for money for a small business grant. And in this grant, we promised that we will use erythropoietin coding RNA and show that we can increase the hematocrit. So in between, we also spent like 2 years figuring out how to purify the RNA. And finally, we had pseudouridine modified RNA purified, optimized, and we found that when we injected, you can see here, 0.1 microgram. If you work with nucleic acid, you appreciate that. 0.1 microgram was sufficient to maintain for 4 days. We could detect the EPO protein in animals, and the half-life of this protein is 2 hours. So if you inject the protein, a big dose, you can measure at 6 hours, and then it disappears. So it means that you continuous production, translation of the RNA went at least 4 days. A single injection, we could see hematocrit increase, and when weekly injected 0.1 microgram, we could maintain high hematocrit value. And importantly, this nucleoside-modified RNA did not induce any interferon. And at that point, all of a sudden already Moderna was formed and others, and I accidentally learned about BioNTech. I already learned that at 2012, BioNTech already had a clinical trial with RNA, started with Ugur just presented for intranodal injection. And so I thought that, I had an offer from Moderna, but they didn't have any RNA yet, and I thought that maybe, it takes for so long time to figure out how to make a GMP RNA, and by that time I might be dead, so I rather just go to BioNTech and join forces with Ozlem and Ugur. And we were not in this fancy building, that we were on the campus, and again, our website, we had a website, but it was not functional, under construction for 1 or 2 years. And so I was happy that I was here, and then first we wrote a big review together about mRNA. And what we were doing is further improving the RNA purification. And something what I have done at University of Pennsylvania, some of the things that had to be scaled up, the purification and so on. And what happened is, at the end of it, that from this tiny little amount of protein, now we had a lot of protein, extended time, and so it was ready for prime time. I was hired at the BioNTech also not for vaccine project, but for therapeutic application of the RNA. And we work on one of the things was its bispecific antibody, again, a very short half-life. There are some in clinical trial. Actually, what we developed and we published on this, where is a bispecific antibody recognizing this Claudin 6 and CD3 on the immune cells, this actually already in clinical trial. And here we showed in animal studies and published in that how it is eliminated, established large tumor in mice. We have done another project, and that was when we intratumorally injected the RNA for treating the animals, and this making, injecting these oops. You see that I am not working with PC, yeah. So we injected the mRNA coding for these cytokines and making the cold tumor hot, and those immune cells which get generated, circulated, and eliminated tumor from the remotely located site, like from the lung. And this, with the Sanofi, went to clinical trial. And many people, I don't have to say anything about, we just heard about how the vaccine was developed for SARS-CoV-2, but many people thought that this was the first time when human was injected with nucleoside-modified RNA, but here I am showing you that 2018, February, Moderna, for example, already used VEGF-A mRNA. This was nucleoside-modified RNA for patients who have undergoing elective bypass surgeries. And although this study was in phase 2 trial and resulted good data, we learned recently that they were not continuing on the trial. So this VEGF-A generate new blood vessels, and they inject it to the patient who needed a salvage of some tissue, which already still alive, but was like a penumbra, where not enough vascular circulation was present. And another study, which was again in human trial, where a nucleoside-modified RNA was used for Cas9 mRNA, and these were a company in Boston, in Intellia, was using. And this patient has amyloidosis, and after diagnosis is about like 5 years later, they usually die. And what Intellia did, they did lipid nanoparticles, what they injected to the patient IV, and this contains Cas9 mRNA and the guide RNA. And the translated RNA, Cas9 RNA, was made a complex with the guide RNA entering to the nuclei, and then changed the genome in the hepatocyte where interrupted, and so as a result of it, there were no misfolded toxic protein was produced. This is ongoing. The patient who were treated with a higher dose of, and only one injection, is permanently changed, the patient, and they are still not making any kind of toxic protein. And because I have never get the R01, I cannot say thanks to my students, because I had none, not one, but I had colleagues, who I work, and I am very grateful to them, that especially at BioNTech, that I had a team to work with. And I am also very, very grateful to my own family. I might say, I like to brag, I have a 2-time Olympic champion daughter. So for the students here, I can say that you can be a mother and you can be a scientist. I'm also very grateful husband. Without him, I would not be able to do that. And actually today is our 42nd wedding anniversary today. Vimane, US. Thank you for staying that long.
What is the effect, if any, of pseudouridine on each codon specificity? Say you have a UUU codon and you have a pseudo-U at first base, second base, third base. Does it change the fidelity of translation?
This year, 2 papers came out, one of them describing whether the transcriptional fidelity, another is that whether the translational fidelity. And actually, sorry. Okay, so it was analyzed for 1-methyl-pseudouridine and suggested that it was actually higher fidelity. And so that's was just published by others, so that it was not, I know that there were some paper, or actually one paper, Carioli, that he published that if the stop codon has pseudouridine, then there is a read-through. In this year, together with fellow scientists from Israel, we demonstrated that we cannot reproduce that part, so that actually if the stop codon contains pseudouridine, more likely that it will be, the fidelity will be higher.
Is there an explanation for why you make more protein?
So one of the things, so there are RNases everywhere, you know, on the skin, on the blood, and everywhere. And there are in the endosome, but of course in the cytoplasm you don't really have, because, you know, you have the RNA there. But when you have the double-stranded RNA, that, which induce the OAS and then can activate RNase L, then, you know, when people generated mRNA, many times they had double-stranded RNA contaminant there. So when they delivered that, they can activate, and we demonstrated that RNase L, which was this 2', 5' activated enzyme, when it is pseudouridine, it did not cut. So the stability in the cytoplasm was higher.
Can you comment where the circular RNA field is going in your view?
My 1991, 92, 1993, I had a, you know, proposed, and I made circular RNA. Last time I showed it just because people say that's a new thing. I already had rejected grant on circular RNA in 93. So in my view, you know, is that those experiments, when they demonstrated that it is not immunogenic, you know, because they made uridine containing, those were, for example, in animal studies, and the mice doesn't have Toll-8, and those were culture cells, which doesn't have T2 RNAs, so they couldn't see that actually all of the RNAs chop up. So I suggested to the Orna CEO that they should check in human primary cells, or at least, you know, human dendritic cells, to see that it is still not immunogenic, because I thought that it is an assumption just. So RNases is present in the endosome, in the immune cells, and they will chop up. And also, you know, some always escape, but, you know, the immunogenicity could be an issue. But, you know, if they use for other things where immunogenicity is required, that's fine.
Yeah. Are there examples of viruses that would incorporate modified uridine so that they would escape innate immune recognition?
Yes, so it was actually, beginning was discovered that many of the viruses had M6A modification, and the SARS-CoV-2 has also modifications, nucleoside heavily modified. And
but still, they remain heavily inducers of type 1 interferon response, so wouldn't you expect that maybe this would be selected for?
So that, you know, they hide in different ways because, you know, the RNA is not exposed, but, you know, it can have immune evasion that, you know, they have modified nucleosides in present. And many of the viruses contains modification.
In the very back up there.
Here. So thank you very much for a very interesting presentation. I had a question on this M6A, just to follow up. Because in your RNA selection experiment, you did not see any value for M6A incorporation in suppressing innate immune response, right? But we know, as you said, viruses do acquire and that has protective value.
Yeah.
So the question is it the sequence context of the RNA that we use?
So, I didn't, but if you look at the paper we published in 2005, there are several things was not answered. And one of them, that when we tested out the nucleoside modified, whether it was M6A, and we put to the human dendritic cells, which was generated from monocyte, so it is monocyte derived, it was generated in vitro, M6A was not immunogenic at all, didn't induce. But when we did the isolated, which was isolated from the blood, we found that only the uridine containing. So there are other sensors which, you know, you will discover. The young one is here. And so there are other sensors probably there too, which might be, you know, sensitive for other, like the M6A.
Okay, thank you, Katalin. Before we start clapping, I would like to say thank you to Katalin. Thank you to all the speakers of this session, to all the speakers of the day. That was, to my mind, super inspirational science we heard today. That's the purpose of the Jeantet and Jeantet Katalin Prize, to recognize super inspirational science. And I think we achieved that with flying colors today. So thank you to all of you. And of course, thank you to everybody who worked behind the scenes to make it such a great symposium. Thank you.